we like to celebrate the first use of dialysis in the United States, which occurred at Mount Sinai in 1948. But also, Sinai actually has several other firsts. As you know, the first dialysis unit in New York City was also built at Mount Sinai in 1957. And the first kidney transplant was performed at Mount Sinai in 1967. The first CAVH was performed at Mount Sinai in 1977. So we did a lot first at Mount Sinai. Very proud of that. So a little bit of history of the division. So division nephrology was created in 1959 by Dr. Marvin Levitt. Dr. Marvin Levitt got training with Dr. Holmes Smith. All the nephrology knows Dr. Holmes Smith, the father of renal physiology. So he is not only a nephrologist, but also a physiologist. So division is very strong on fluid electrolyte, and his research is mostly on the mechanism of diuretics. Then in 1989, Dr. Richard Stein took over the division chief position, and his research interest is also on fluid electrolyte. So Sinai division nephrology has always been very strong on fluid electrolytes. In 1994, Paul Klotman was named the division chief by Dr. Barry Kohler at that time. And what he did is really change the division from a clinical division to a more academic division. And he built a strong research program for the divisions. And then Dr. Murphy took over in 2001, and she actually really, further expanded the division in terms of research, education, and the clinical care. And I took over the division chief position in 2013. So I've been division chief for almost 10 years. And I joined Sinai as a fellow in 2000. So I've been at Sinai for almost now 23 years. So I'd like to, today to honor memory of two wonderful women nephrologists in the division. One is Dr. Ruth Abramson. Most of us know her. So Dr. Abramson was a professor, but also in the IB chair, associate dean for research. And most importantly, she was a PD, the program director for nephrology fellowship. And many of us she's a mentor for many of us. And really, I think she helped to build a strong nephrology fellowship program at Mount Sinai. So now every year we have this called Ruth Abramson lecture in honor of her, The second one everybody knows is Dr. Murphy. She passed away 2 years ago, and I don't need to say anything because all of us knows very well. But we will remember what she has done for us, for the division, and she really made this huge contribution to the growth of the division nephrology at Mount Sinai. So what's the current status for the divisions? So we have now actually one of the largest divisions of nephrology in the country with 60 faculty. We have a couple of divisions, the faculty from other professors from other division in the countries. But I think with 60 faculty, we have one of the largest divisions of nephrology in the countries. And division manage about 18 outpatient dialysis centers across New York City, and we have more than 1,000 ESKD patients now. We always have the largest the home dialysis program in New York City. We also developed this very innovative CKD program together with Renalytics, a diagnostic company. We also have one of the highest NIH-funded division in the country with now 20 NIH-funded PIs and more than $50 million NIH funding annually. And we also have one of the largest and the best fellowship training program in the country with multiple subspecialty tracks. So this is actually a list of all hemodialysis centers that we managed in the New York City. It's across the New York City in Manhattan, Bronx, and Brooklyn. I'd like to also acknowledge Dr. Tukida, who's the clinical director of nephrology, and Ms. Yvette Cumming is a nursing director for the dialysis unit. Both of them provide overall supervision of the dialysis operation at Mount Sinai. So Mount Sinai also owns a dialysis center at 170th Street now. It was 94th Street. And this is actually only hospital-owned dialysis center in New York City. And many people actually being the medical director for this unit. And now we have we just recruited a new director, Dr. Niraj Kothari. And in the past, I think Dr. Winston, I think, was the first medical director for 94th Street, and Dr. Yubari was the director too, and Dr. Vasalati, and then I think Brian Radbill, and Joe Vasalati, Brian Radbill, and Vijay, I think. So many people actually served the medical director for this unit. And then, for the home program, as I mentioned to you, we have the largest program in New York City. And Dr. Yubari is being, the medical director for many years. And today we also have Dr. Juan Bosch, who was the first medical director for the PD unit at Mount Sinai. And Dr. Sharma is an associate director for this program. And we are very proud, we have a lot first also for this unit. We first used this tiny, actually, like, called cycle, PD cycle, IMS PD cycle at Mount Sinai. And, you see the older one is huge. Now we have just like iPad size, it's great. And we also have one of the first actually home dialysis fellowship training program at Mount Sinai. So I have to mention also, we have a, wonderful nephrologist at, both Morningside and Mount Sinai West, and Dr. Marcel is the chief nephrologist there, and we have, also managed 4 outpatient dialysis units there, and the largest nephrology practice actually on the west side in New York City. And then the Mount Sinai in downtown, we have, Dr. O'Neill is the medical director. So we also manage additional 3 outpatient dialysis units at downtown. So we also, over the last several years, we established this CKD program, which is very important. We are focusing on 3 major areas. The first area is try to identify and manage the early CKD patient, because even though we like the dialysis, but we don't want the patient to progress to dialysis. So we try to identify the high-risk patient population and to have early intervention and try to prevent the progression of CKD to ESRD. Secondly, we like to make sure that the patient with advanced CKD, they have a smooth transition from CKD to ESRD. The third one, the one patient reached the ESRD, we try to make sure the patient get the transplant first, and then the PD second, the in-center dialysis the last. And over the last several years, our transplant referrals being also increased by 30% at Mount Sinai. So to do that, we also have this company called Renalytics Diagnostic Company, which can help us to really to stratify and identify the high-risk CKD patient. Therefore, we can have an intensive management of this particular high-risk patient population. So the research-wise, the division has a very strong research. We have 2 centers. The one center, actually, Dr. Kraft has not announced yet, but I try, just let you know. So it's called Mount Sinai CKDI. The second one is the Transplant Research Centers. And we have in the division total, we have more than 20 PIs. And currently we have a 24 R1U1 big grant and many K grant too. And the total funding level is like about $15 million in each funding. We also have a lot of collaboration with the RPM Institute of Precision Medicine, and Girish, is Nadkarni is the director for this unit. So we take advantage by me by bank, and we also have developed a kidney tissue biobank and been collecting a lot of samples over years. So this center is called Mount Sinai Center for Kidney Disease Innovation. It's a new center, and Dr. Cook Campbell will be the director of this center. Essentially, this center aims to, using the system of biology as a tool to identify potential drug target and a new drug for the treatment of the kidney disease, because, we still don't have enough drug for the treatment for the patient with chronic kidney disease. So that's the goal of this center. And we also have a center for the Translational Transplant Research Center. The director is Dr. Paolo Crevedi, And this center also tried to develop a biomarker and understand the mechanism of immunoreaction, rejection for the transplant patient. Therefore, we can improve the quality of the patient care for the transplant patient. And Dr. Steve Coca is the director for the biomarker core in the division of nephrology. He's a founder for the actual renolytics, and the group actually tried to continue to identify the new biomarker and try to improve the predictive value of this renolytics AR system. The other things I want to mention is that in the division, we also have this bioengineer lab. The one thing they did is the director is Evan Aziloglu, and their group actually tried to do is using the bioengineer technology to improve the vascular access, develop some called implantable vascular access devices. And they already did a preclinical study, which shows a very nice result. So it's going to be the first use in human trials. And this kind of new device can help, I think, to reduce the bleeding or prolong the life of the AV fistula. So this is also very actually innovative technology. So this is all the research, I think, which is very important, and hopefully we can translate all this research into clinical care and improve the quality of the CKD patient and the transplant patient. The last slide I want to show you also, we have a very strong fellowship program and led by 4 wonderful women nephrologists in the divisions. And we have 7 fellows each year, and it's a really big program and have a lot of combined program, transplant nephrology, combined nephrology palliative care program, nephrology critical care program, home dialysis program, GN program, onconephrology program. So there's a lot of options for fellows. We also have a training, NIH-funded training program to training the research for the fellows. Over years, we have trained many fellows actually, and they become actually the leader in nephrology in the countries. So lastly, I just want to thank all the faculty in the division of nephrology. This picture actually was taken like a couple of years before the pandemic, at the ASN. During the pandemic, we did not have any reception, so we don't have any pictures. But this year, actually, we're going to have a reception again, and I will welcome all of you to come to Mount Sinai in the reception at the ASN, and I'm sure we're going to have another picture. Thank you very much. And
thank you, Dr. He. Sorry. Next in the agenda, I want to present Dr. Juan Bosch, who is the professor of medicine at the University at George Washington University in Washington, D.C. Dr. Bosch is one of the main connections with dialysis at Mount Sinai in the past that we have right now. Most of the faculty are newer, and the connection has been lost. Of course, there is nobody who was here in 1948, because that will imply a very long survival, and I'm not aware of anyone surviving. And obviously, Dr. Bosch, although he has some seniority, he's not of that seniority. But he came here in the 1970s, so that is close enough to the 1948. And therefore, it is important the perspective that he has of what dialysis was in the 70s and in the 80s. Dr. Bosch, happy to have you here.
Thank you very much. Now, what button do I push now without disappearing?
Okay.
All right, just put the first slide.
The first slide, I forgot to click on it.
Yeah, thank you.
No, you know.
And to move forward, this one?
Yeah.
Okay. Well, thank you very much, Jaime, Dr. Xie, for inviting me. It's an incredible pleasure to be here after so many years. And I just want to tell you that The years I lived here were very exciting, and I just want to show you a little bit of what those years were. First, I started with this slide because the original renal division was in the atrium building, in the laboratories, before they built the Annenberg. And when they built the Annenberg building, we moved to the 23rd floor, and it was a fantastic building, a fantastic. We have still technical issue? No. All right. Okay. And when the building came, everybody said, "Ooh, it's so rusty." And the architect said, no, it will turn black. Still look rusty to me, but I mean, that's my perspective. Okay, let's see, next slide here.
No.
Okay.
Sorry.
In 1973, when I became a fellow at Mount Sinai, these were the members of the renal division. As you can see, were small. I wish I could say something about each of them, because each of them were a character, fantastic people, a little special, but it had a vitality that everything was possible. And if you ask me what was the most important things I learned, was that we always had to think that behind every symptom, there was a mechanism. And unless you understood the mechanism, the physiology of that, you could never understand the symptoms and treat the patients. I was a partner with Shelley Glabman for more than 10 years, and in the Robert Wood Johnson Treatment Center. But my mentor and the person who really made me was Dr. Khan. Tom was a fantastic guy. I don't know if he's here, but hey, Tom. Tom and I have a great time. No, Tom, I did it on purpose because I knew that you were going to say that. Anyway. You already said that this, I think, are the big steps in Sinai. 1948, the first hemodialysis. I just want to mention that the person who did the first hemodialysis was Dr. Irving Krupp, who had been my attending in the Brooklyn Jewish Hospital. And he always said to me that they didn't like it because it was too bloody. In 1973, there was a very small hemodialysis unit here. And there were only 5 units, and they were staffed by people who had been, the technicians had been in Vietnam, and they were very good, and they knew, it works very well. Now, the renal fellows covered this dialysis clinic in the evening because our salary was very low because we were in an NIH fellowship, so they pay us extra. Now, at that time, I spent the evenings and we will finish at 11:30 at night. So it was really boring. But Tom and I have been doing experiments with a blood gases machine. So I went to this, in this hours doing nothing, I just drew blood from the dialysis patients before and after the dialyzer. And I saw incredible changes in the PCO2, in the bicarbonate. So I collected the data, showed it in the grand rounds, and they said to me, "We don't know anything about this. We don't understand anything that's going on. You have to go and talk to the people at Elmhurst, where they had a big dialysis group. Also, they look at the data and say, we don't understand anything. I mean, anyway, at this moment, I realized that dialysis was a gigantic field because nobody knew what they were doing, and there were lots of people on dialysis. So that is my interest. I want to start here saying that in the 70s, the big dilemma in dialysis was there is something that we are not removing from the patients, and that is why the patient don't do well. And that was the middle molecule hypothesis, and basically said that it's just, there's something that we don't remove. Now, it was interesting that Dr. Henderson, who was in La Jolla, in Pennsylvania, and then in La Jolla, he was very interested in convection, that is ultrafiltration or the transport of water through membranes. And he did the first studies on peritoneal dialysis with glucose. But at that time, then he said, what happened is that when you do hemodialysis, you're using diffusive transport. And the diffusive transport, the small molecules of urea compete for the pores of the membrane, and they do not let pass larger molecules. Therefore, the way to go is to avoid diffusion and use convection as a way to remove the solute during dialysis. Simultaneously, at that time in the 70s, a small company in Lexington, Massachusetts, had created a membrane to be used in Vietnam to purify the water, so that the soldiers that were in the jungle, they could take this membrane and purify the water and drink it safely. And this was very interesting because at that moment, the only membrane in use in dialysis had been membranes derived by the cuprophane or cellophane. And this membrane was very important because it was highly permeable to water. And this was the asymmetric membrane, and that's a picture of it. So this membrane allowed the blood, the great permeability for plasma water. And in fact, there was the first proposal for therapy was Dr. Lee Henderson, and I have the reference there. Basically, he said, we're going to use this membrane that have high permeability of water to dilute the blood as the blood enters the filter, and we'll obtain a large amount of ultrafiltrate, and we will do the dialysis. That is the kinetic hemodiafiltration, which was the first paper on the topic. Now, this method required the injection of sterile fluid to pre-dilute the blood in about 200 mLs per minute. That was a gigantic amount of fluid. And he proposed this, and he did one or two experiments, and there are beautiful pictures of him surrounded by bottles of saline hanging in where he's trying to replace the fluid. But he did create the concept. Listen, there is a way that you can do it. This is more effective in remove these phantom molecules. In Europe, there were others who also wanted to do this, but they didn't have this membrane. But they had another membrane, which is the acrylonitrile membrane, and it was a little more permeable. But Dr. Quellhorst in Germany published this first paper in where he said, you can do this without having any pre-dilution or any fluid entering the blood. You just can filter it and replace it after the filter. Unfortunately, it would take 8 hours to obtain about 12 liters of ultrafiltrate, which obviously was not enough to clear the urea nitrogen that was required for dialysis. But he did this and was successful in achieving being able to have some patients who tolerated this treatment. In 1977, the NIH asked for proposals for implementation of hemofiltration in the United States. Dr. Albertini, Tom Kahn, and I worked hours, days in this presentation in preparing for this, and we were granted the grant to do this hemofiltration. Now, there were a lot of challenges that we had to face. First, this new hemofiltration therapy, could not last longer than the conventional dialysis, 4 hours, because in the United States, nobody would stay for an experiment if it were more longer than 4 hours. So this is incredibly difficult. Larger blood flow than those used in conventional hemodialysis had to be explored. A special blood pump had to be used. At that time, the maximal blood flow used in dialysis was about 200, 250 mLs of blood. We needed at least 300 or more to be able to do the treatment. Now, everybody said it cannot be done. Anyway, we were able to get some companies to build a special blood pump for us, and we were able to obtain this larger blood flow without any side effect for the patient. Then we had to develop a system in where, as we are removing now 100 mLs of ultrafiltrate per minute, we had to give 100 mLs or 90 mLs of substitution fluid. This balance had to be very careful. So we went to Italy in a small town near Modena, where all dialysis has invented, and we found a person who built for us this special gravimetric system. In other words, a system that was able to replace the fluid that we were taking out with infusing fluid. But the largest problem we had was that we would need extraordinary quantities of fluid.
Yeah.
Okay, thank you. All right, so we had to produce an enormous amount of fluid. Remember, our proposal was that our treatment had to be the same as the dialysis treatment. So our calculation meant that we had to, each treatment, we had to ultrafiltrate 20 liters, 24 liters from the patient and replace it with 20 liters of sterile fluid. 20 liters per patient, okay. So this was a tremendous challenge in terms of volume. Now, here I will show you how do we solve this. First, there were no medical grade plastic bags larger than 500 ml available in the United States. So we had to go to Germany and import bags for 20 liters of fluid. Gigantic bags. Then we produced the sterile fluid using a technique that Dr. Henderson had used, which was to use the dialysate to go through the same membrane. And so we put the dialysis machine, the dialysate part, pump it through the filter, accumulate it in a sterile container, and then put it into the bags. This was fantastic. We had this gigantic bag now filled with fluid. But the bags were extremely fragile because they had not been heated. So every time the nurse would touch it, boom, it would explode. It was a catastrophe. So we were very desperate. What do we do? Now, Dr. Albertini was like a Swiss knife. He was had a blade for everything. So he found that on top of the dialysis clinic, there was an abandoned gas sterilizer. So he said, Juan, we have a problem. We have a solution. So we put the bags inside the gas sterilizer, and they all burst. So, oof, but no problem. We went to Sears, and we bought a compressor. And we connected the compressor to this gas sterilizer. And then still there was bursting of the bags. But again, we were resourceful, and we decided the way to do it was to put food colorant to the bag. So the green bags were on the top rack, the red bag on the bottom. So then Beat would operate the compressor, and if I would see green coming, meant that it was not enough pressure on the top line. So increase the pressure, or, an impact. So it worked. At the end of the day, we were able to produce these sterile bags with the 20 liters. That was very important. So, and in doing that, we became the third largest producer of sterile fluid in the United States. Because remember, there were 8 patients, 20 liters per treatment, 4 treatments a week. It was just 400 liters, nothing for us to make. In fact, the NIH came to us because at that time, the only plastic bags were 500 cc's for plasma transfusions. And PD fluid came in 2 liters bottles, glass bottles. So we went to the US Pharmacopoeia and they changed the bags and eliminate the glass bottles in PD. And so we were in business. And finally, because at that time, I hope so too now, the whole hospital had the same enthusiasm that we had. And the pharmacy finally decided that they would take care of the production of the fluid, and an enormous burden was lifted from us. So Dr. Bernie Mell was the person, and he was great. Anyway, so we created this treatment, which basically, and I want to mention here, Bob Geronimus, who had been chief resident here at Sinai, he was working with me, was my first fellow, and he helped us, and we did all this together, Tom, etc. Here, so we created a treatment that was basically with very small amount of fluid in the pre-dilution. Why is this? Dr. Henderson used pre-dilution because he was afraid that the blood would get too concentrated inside the filter, and that would result in hemolysis. But Dr. Levitt said to me one day, "Don't you know that filtration fraction in congested failure is 80%? So I said, well, then we can use 80% and nothing will happen. In fact, nothing happened. So we used that and the post-dilution fluid. So we were obtaining, as I said, 100 cc's per minute, and the treatment lasted 4 hours, so it was about 24 liters that we took out from the patient that are the volume. Now, in April '95, Kenneth Liverman, who was a pediatrician here, had a case of a little baby that had been born from a abrupto placenta and had renal failure. At that time, there were no equipment for pediatrics. So he came to us and said, can we do something? And because we were fearless and stupid, he said, yeah, we will help you. And we did this, we treat this baby. He did well. For years, the mother sent me cards for birthday. It was just fantastic. So Ken had published this in '95. Then I went to GW, and we continued doing the hemofiltration, and we published in 2006 what we felt were the great benefits of all convective therapies. Patient tolerance. Patients' treatment tolerance was much better. Hypertension was never a problem. There were no cramps. It was just simply a lot of benefits, but it came and gone, and nobody paid attention. Now, in July 23, now this is it, there was an article in the New England Journal of Medicine saying that these convective therapies were beneficial and resulted in less mortality than standard hemodialysis. It was not a surprise to me, but I guess for the New England it was. The real question for you is, how come it takes 20 years to accept that the treatment is better? I mean, it seems to me that there is something wrong in the system, because that's the way it is. So I just briefly tell you what I think were the legacies of these contributions here. One is, I think, the increase in the blood flow in dialysis became widespread. And that brought as a consequence that acetate could not be longer used as a dialysate. and we shift to bicarbonate because the quantity of acetate being administered exceeded the capacity of most patients to metabolize it, and they would have cramps and all kinds of side effects. Again, the most important thing was that it was shown that the treatment tolerance with convective therapies was much more effective. But this was let it go. Now, and again, I think that the high efficiency treatments and hemofiltration have survived, and in Europe is very extensively used. So what are the missed legacies? I think the most important missed legacy in the dialysis community today is that they continue to talk about weight loss is not equal to sodium loss. They have forgotten that ultrafiltration, weight loss, they say weight loss, 2 kilos, 2 liters of ultrafiltration. It's wrong. Ultrafiltration is, the important thing of ultrafiltration is the removal of sodium and water. And this is accordingly to strict donor equilibrium principles. And therefore, if you do not pay attention to what is the plasma sodium and what is the sodium in the dialysate, you result that you remove water, but you give sodium back. And this is the consequence of why so many patients have hypertension, lack of tolerance of the treatment, etc. Not to say a thing about in peritoneal dialysis, in where the ultrafiltration or water removal is extremely hypotonic. And that results in that over time, patients cannot overcome this syndrome of too much water and not enough removal. So this, I think that I fault seriously the dialysis industry that has been unable to address the issue of the individualization of the sodium for the patient in the dialysate. Everything is now for everybody the same, and that's not the case. So therefore, I think that this cannot be. I mean, it's so many years now, and you still continue to do this nonsense. Ultrafiltration in dialysis is not isotonic. It's, if anything, hypertonic. Patients are gaining sodium every treatment because the sodium is too high. Anyway, that's, I think, is a very important miss. Anyway, but in the midst of, since we have nothing else to do, we continue to do things. And at that time, it was very common in the patient had open heart surgery, and they received they had these extracorporeal circulation, which had was primed with sodium and saline, and then at the end of the treatment, the patients were gigantically ballooned, and most of them have renal failure. So they would call us to do dialysis, but it was sometimes impossible because they had severe hypotension. So then we said, well, we're going to use this little filter. We put it in the vein, the artery, and see what happened. And it worked really well. And we were able to remove lots of fluid from these patients. And then we used to collect this urine collector as a sort of to create a negative pressure for the fluid to come. So if you lower the bed, the negative pressure on the top of the column will increase and the ultrafiltrate will increase. So it was a really homemade treatment for volume or renal insufficiency. It demanded tremendous work because the filter would clot in the middle of the night. So the fellows slept here. Everybody, it was just, the nurses didn't complain. Everybody was, we're doing something really nice. Now, the tipping point was this. I used to share the lab with Josie Briggs, and Joseph Briggs did micropuncture. So one day, as we were having coffee, we used to have in Ruth Abronson's lab, she always said that I was not neat because I was spilling the coffee. Anyway, but she was extremely neat. Anyway, so I said, Josie, how do you figure out single nephron GFR? How do you do all this? It's really simple. I mean, I take a sample from the afferent artery, from the efferent artery, I calculate, and the single nephron GFR, I calculate the filtration fraction, and that's it. And this is what this formula is. Suddenly, in my head, said, wow, we have it. I mean, in the filter now, I will do exactly the same. I have all the measurements possible, and we did describe what are the different factors that were influential in the permeability in the filter. And then we realized that was interesting that as the filtration fraction increases, then the pressure was top, so that it was a filtration pressure equilibrium in the filter, so that our filter was too long and we had to shorten it. So once we understood the mechanism, and I think that this was the beauty of having to work with somebody else doing something different and being able to talk, not by Zoom, but by person. Say, hey. And this really opened our eyes, and we were able to create many filters and developed because we understood now what were the factors that are responsible for the filtration within the filter. Now, still, it was tough, so then eventually I worked with a company to develop this Prisma machine, which is today is called PrismaFlex, and I have had the pleasure to see it in almost every hospital around the globe doing this therapy. So I want to tell you that when we started doing this, I was in every intensive care conference in the country, and they were nephrologists were not very much interested. But eventually, it became very popular, and today is used around the globe. I want to tell you something which I find very important, that innovation in medicine, to me, is like a river. And the river goes, and there are many affluents that bring water here, there, and finally, when it reaches the ocean, it's hard to know which river and which contribute to what. And I think this is the case in all of these things that I show you. I think the important thing is to give something to the medical community, and then the doctors who have the courage to try use it differently. I am appalled how little innovation has occurred in dialysis. I mean, we work extremely hard, but we did good things, I think. Anyway, I want to thank mostly the nurses. I mean, my collaborators have all the thanks by being in the papers, but the nurses who save us so many times. I remember one time we are in a room and we are putting one of these new filters in the patient, and it's Albertini, Geronimus, and me, and the patient goes, ugh. We almost died there. But here comes the head nurse and said, get out of the room, I'll take care of it. So, thank you, nurses. Wait, I haven't finished. Sorry. And I want to finish with my final comment is this. I live in Washington most of the time, and I see these people in the boat. And I think it's a fantastic metaphor for you. Look, be a team. Be a team. Look backwards, but always go forward at high speed. Thank you.
We have time perhaps for one or two questions if anyone wants to make it, or we may leave it at the end of the whole session. Apparently, we'll leave it at the end of the whole session. Thank you very much. So we'll continue the program then. This time, we're going to switch completely not completely, but I mean, going from the daily details about how to innovate in dialysis of ultrafiltration. We're going to have Dr. Kevin Erickson, who's an associate professor of medicine at Baylor College of Medicine, whose research focuses more on health economics, policy, and outcome in kidney failure. And he's going to tell us what has happened over the 50 years of history of a national program for the treatment in kidney failure in this country. So let's welcome Dr.
Well, I want to thank the organizers for inviting me to talk here, and thank you all for being here. Yeah, so you're going to be hearing a lot about the dialysis over the past 50 to 75 years from a lot of different perspectives today. My talk is going to be focusing on policy, a little bit of epidemiology, and I know later you're going to be hearing about technology as well and innovation. Okay, thank you. So here are some disclosures. And so I'll start. So 50 years ago, on October 30th, 1972, Richard Nixon signed the Social Security Amendments of 1972. And this created the U.S. End-Stage Renal Disease Program, which extended Medicare benefits to people with kidney failure regardless of age. So this was essentially a national health care system for people with end-stage kidney disease. Passage of this bill did not happen overnight. There were a number of sort of developments that happened to lead to this, and in two broad areas. One was in developments in innovation, and the other was developments in political support. So if we start with innovation, and again, we're going to hear more about this later today, but we had kidney transplantation, which started. The first kidney transplant occurred in 1950. Here are the doctors and the patient who was transplanted. I think this one only lasted a couple weeks. And then in 1954, you had a transplant with some involving identical twins that lasted longer. I put them both here because I was trying to research when the first transplant was, and there seems to be dueling narratives about which one counts as the first transplant. So I thought I'd give them all credit. But you had transplantation starting in the 1950s. Then you had innovation in dialysis machines. We see the old like rotating drum machine and newer machines. Obviously, there's a whole lot of innovation that happened between these two pictures, leading to safer dialysis, shorter treatments, and then finally, innovation in vascular access. I think this was the biggie because now patients could go get their treatment, have the access cannulated, leave with this access from the Scribner shunt, and come back. And so really it was those three things that made it so in 1960, you finally had it was possible where you could treat chronic uremia with dialysis. Now the problem was that it was not cheap, and most patients couldn't afford this. And so really there was limited access to this life-saving treatment. And so even though you had the ability to treat people, people were still dying of uremia. So then we shift to the political movement and political support. So this was part of a broader support towards public financing of healthcare. In 1965, the Medicare program was enacted, leading to financing for healthcare for the elderly. And there was a continued momentum after this was passed in 1965. There was movement, a lot of people calling for a national healthcare system in the late 1960s. And the sort of idea that the government should provide healthcare and access to healthcare for a larger segment of population came into direct conflict with what was happening in the kidney area, which was there were only a couple centers that were doing hemodialysis. There weren't enough funds to provide this procedure. And so you had rationing of healthcare at a high level. And this was brought to light in a 1962 Life magazine feature where they talked about these in one panel in particular who decided what patients would ultimately get dialysis treatment, what patients wouldn't, and would die from uremia. And so, the sort of idea that we should be providing healthcare for everybody, and at the same time we have this severe rationing of healthcare created conflicts. And so every congressional body between 1965 and 1972 introduced some kind of bill to expand government financing for kidney failure. In 1966, the White House convened a committee, that, excuse my pronunciation, Gottschalk report, and it called for federally assisted national program to provide dialysis and transplant care. Interestingly, this report, when they tried to estimate how much this program would cost, grossly underestimated the future size of the program. But nevertheless, the ESRD program was signed into law in 1972, perhaps as part of a sort of compromise between those who wanted more health care and those who wanted less. And now patients had access to end-stage renal disease care. There wasn't a lot of fanfare at the time, from what I can tell. I think it was right at the time when this heated presidential election was happening. So didn't get as much press as it might otherwise have gotten. So then we'll start looking at the policies and epidemiology of the ESRD program. And I like to think of it pretty much any health policy. You can think about like three overarching goals. One is to provide access to care. One is to keep costs under control. So, a lot of healthcare, government health policies, you're trying to not spend too much money. And the other is to maintain quality. And so each of these sort of plays itself out in the 50 years of the ESRD program. And it's sort of the tension between all of these that helps us to kind of understand what's happened. So the first is access to care. I think the ESRD program, early on, it was clear that this was providing access to life-saving treatment to people who otherwise would have died of kidney failure. So here we see a report from the early 1980s. It shows the growth in the ESRD enrollment from 1974 to 1981, grew from 15,000 to 64,000, like a 22% annual increase. And importantly, the people having access to ESRD care, it spanned all ages, sex, race, ethnicity. So this was, I think it still continues to be the major success. And that's not to say that there aren't, room for improvement, but access to care really has been a major success of this program throughout its history. The problem was that as enrollment grew and more patients had access to care, costs went up, and it quickly became a concern to policymakers that the dialysis care and transplant care was costing a lot of money. By 1980, Medicare was spending $1.2 billion per year on its ESRD program, and lawmakers ultimately passed a law saying that Medicare needs to bundle payment for the dialysis procedure in an effort to try to control these rising costs. This ended up happening in 1981, where all of the dialysis services received one rate regardless of kind of what you did during the dialysis treatment, again, in an effort to control costs. Payment, and this is a figure from Dr. Himmelfarb, who's here now, a great paper in the early 2000s on this topic. We see that payment for dialysis actually it didn't increase with inflation. I think there were about 4 moments where legislatively it increased, but for the most part, the payment number stayed the same. So when you look at inflation, payment for the dialysis treatment itself in the context of this initial payment bundle went down in inflation-adjusted dollars over the first 30 years of the program. And what I think is implied in this chart and suggested is that in order to keep the cost of dialysis sort of under the payment, there were a lot of efficiencies that were possibly happening in terms of how do you provide dialysis for, at a lower cost over this period. Another thing that lawmakers did in the early 80s was they used the Medicare secondary payer statute to require private insurers to cover costs in the early period of dialysis. Initially, it was like the first 10 months. It's ultimately been extended to the first 30 months of dialysis. Again, another big cost-cutting measure. So did it work? In some ways it did, in some ways it didn't. If you look at, this just shows growth in ESRD expenditures over time. And despite decreasing inflation-adjusted payments for dialysis, you see inflation-adjusted payments for ESRD care going up over time. But interestingly, it's going up really, it's tracking with enrollment. So on the left side, we see the annual expenditures. On the right side, we see the beneficiaries with the ESRD. And so the cost per beneficiary is staying relatively stable, which is unlike every other area in medical care where the cost per beneficiary is going up. Here, it's really the growth in enrollment, which I underlined, that's driving costs. Now, there were some increases in expenditures for things like some of these new intravenous medications that were outside of the bundle. But interestingly, between 1974 and 2004, inflation-adjusted Medicare spending declined actually at 0.6% per beneficiary. So, that bundle sort of worked, but costs were still going up. Why did enrollment growth go up? There's just a sort of list of some of the explanations that have been thrown out there. Growing epidemic of diabetes, increasing hypertension, improved cardiovascular outcomes, so patients were living long enough to develop ESRD over time. We were dialyzing increasingly sicker patients, and patients are living longer on dialysis. So all of this is contributing to enrollment growth, which is making the cost of the program go up, even though there's this effort to control costs. Then if we fast forward to the 2000s, we have another sort of big effort to control costs. So in 2006, a GAO report described increasing use of expensive erythropoietin-stimulating agents for patients receiving dialysis. This is a graph from the report where we see the average dose per administration of 3,000 in 1991 going up, basically doubling by 2006. And so this was outside of that initial payment bundle, and so it was sort of offsetting some of these decreases in costs from the payment for the dialysis procedure itself. And policymakers, lawmakers didn't like this. This was contributing to program costs. And so in 2008, Congress passed a law, the MIPA, which required CMS to expand that bundled payment to include these expensive injectable medications that were formerly separately billable through the program. This happened in 2011, and it had its intended effect. You can see here the use of EPO going down. Actually, kind of when the law was first passed, we started to see it, but it did go down even more in 2011. And some of these cost efficiencies from this decreased use were then sort of recouped by government payers through a process of rebasing. So they would change that the amount that they're paying for the bundle and decrease it to account for these increased efficiencies. And so this was the second sort of big effort to control costs. And we've talked a lot about costs during here because I do think, in terms of the ESRD program, efforts to control costs have really been fundamental to what's happened with policy. So where are we now? Maybe costs could have grown higher if they didn't have these payment bundles. But they still did continue to grow, particularly with enrollment growth. In 2019, you had Medicare spending $37 billion on the care of patients with kidney failure, less than 1% of beneficiaries of Medicare accounting for 7% of expenditures. So I think concerns about cost are still there and still reflected in current policies. We'll shift gears to the next area of concern, quality. So really, also, since almost the beginning of the ESRD program, there have been concerns about quality of care. A lot of this started in the 1980s when that first bundled payment to keep costs down. People said, what's going to happen? What is everyone going to do to keep those costs down? How is that going to affect the quality of care? Here's just a series of sort of commentaries that came out in the early 80s, just all kind of calling out concerns for the quality of care people are receiving in dialysis. Two of the areas that some of these articles touch on, it was seen in the 70s that most of the demand for ESRD was being met by for-profit providers. So already back then, there was concern about the role of for-profits in healthcare and its effects on quality. And then dialyzer reuse was something in the 80s that was discussed a lot. It was a cost-cutting measure, but what happens to quality when that happens? So those are just some of the issues that you see come up in the literature in the 1980s. In 1991, these concerns about quality led the Institute of Medicine, now the National Academy of Medicine, to release a report on quality of care for end-stage kidney disease. And it's really in the wake of this report that we see a lot of the sort of quality initiatives that we think of in the 90s and 2000s. So just as an example, the NKF KDOKI clinical practice guidelines come out after this report, the US RDS special studies studying some of these quality topics in end-stage kidney disease, Fistula First Initiative, annual dialysis facility reports, facility certification processes, ESRD network, quality assurance, and quality improvement activities. All of this sort of comes out of these concerns for quality, about quality, and this IOM report. Another big thing that the report led to was, the government was collecting all of this data through administering the ESRD program. Okay, why don't we use that to actually help try to improve quality? And so it also led to the use of the USRDS and the creation of that and sort of harnessing that data to address some quality concerns. It's not just the USRDS, though. We have a lot of other sources of data now that are being used to monitor quality. Despite all those efforts that I listed that happened in the 1990s, 2000s, if we fast forward to like the early teens, we're still big gaps in quality of care. Just to name a few, patients starting dialysis in the United States. This is data from DOPS, where we see a lot of patients in the US are still starting dialysis with catheters compared to other rich countries. There are other developed countries. At the time, there was still relatively infrequent use of peritoneal dialysis. We were at 7.2%, again, compared to a lot of other countries. And so it's another quality gap. High mortality, there's room for improvement potentially in the technology and how we deliver dialysis. You see sort of in the bottom, ESRD hemodialysis is comparable to in life expectancy to a lot of terminal cancers. And then disparities. I think that the issue in disparities, a lot of it's in leading up to end-stage renal disease, but you see, for example, the incidence of ESRD much higher in Black individuals than other races and ethnicities in the United States. So there are still, it's observed there's still a lot of quality gaps despite all of those initiatives that came out of the IOM report, which brings us into the sort of the modern period, where we have value-based care as a potential solution to the issues around cost and quality. So in 2015, the Secretary of Health and Human Services announced the goal of having 90% of all Medicare fee-for-service payments linked to quality or value by 2018. Don't know that they got there, but this is just an example of some of the value-based payment programs that have been used in Medicare more broadly. And in dialysis care, ESRD care, we have not been spared. This is a slide I made in a talk on pay for performance in ESRD, and these are a lot of the programs that have involved that have affected the treatment of end-stage kidney disease. So they kind of come in two flavors. We talked a lot about these already, the bundled payments, which are really focused on controlling costs. That's the initial prospective payment system in 1982, the expansion of it in 2011, and then sort of modifications of that. So we have rebasing of the bundle, and then more recently incorporation of new medications into the bundled payment. And then we have another set of value-based payment programs that have affected dialysis care. They're really focusing on pay for performance and value-based payment. For example, reforming the physician payment in 2004, the ESRD Quality Incentive Program, then more recently ESCOs, MIPS, and in 2019, the Advancing American Kidney Health Initiative, which created these value-based payment programs encouraging home dialysis use and transplant. So to go back to these sort of three areas of health policy, we can just kind of review access. As I mentioned, passage of the ESRD program, I think, was a real success in providing access to care, but there still are areas to improve in access to care. Efforts to, for example, expand access to home dialysis, transplantation. Didn't list it here, but access to care for people who don't qualify for Medicare is another big issue. Cost, we see bundled payment as sort of a big driving force of trying to control costs of ESRD care. Along with that, there's likely efficiencies in dialysis delivery that were happening to bring costs down. And then more recently, the newer value-based payment programs that are paying for value, one of the things they're paying for is reducing costs or providing higher quality for the same cost, or however you want to think of value. And then finally, quality, we mentioned a lot of national and state and private quality initiatives, value-based payment programs, again, focus on encouraging high quality of care. And then I mentioned the use of these sort of big data to try to actually monitor quality of care through administrative data has been a big part of quality monitoring. So I'll finish with some challenges I don't think those goals are going to change. I think those are still going to be what we're all trying to achieve is, providing high quality of care, access to care at a reasonable cost. What are the challenges that as a community we're all going to face trying to achieve these goals going forward? One has to do, I think, with the composition of the dialysis provider markets. U.S. markets for the provision of dialysis are highly concentrated. More than about 75% of patients currently receive care from two organizations. Some research I did suggested on average patients have about 2 competing facilities to choose from, so they don't have a lot of choice. And highly concentrated markets are associated in some instances with worse health outcomes, and I say likely increase costs for private insurers and Medicare Advantage. So it's going to be this is going to be a sort of impediment to I think, progress going forward. The 21st Century's Cure Act is another sort of potential issue. So this was a law that made it so patients with end-stage kidney disease on dialysis can switch into Medicare Advantage programs after they develop ESRD. That wasn't really allowed or permitted before. And so we see in 2021 a lot of patients shifting over to Medicare Advantage. And it's just not known what's the quality of care going to be like in these programs. And a lot of I mentioned sort of big data that's been used to monitor quality and things like dialysis facility reports, like that's not as available in Medicare Advantage. So we've lost some of our ability to actually monitor quality, unless these data can be made more accessible and better. And then recently, about a year ago, the U.S. Supreme Court made a ruling that could change the role of private insurers in dialysis. So this is a ruling that could, I guess, big picture, could ultimately force some patients with private insurance to sort of forego their private insurance and switch to Medicare in those first 30 months, which could sort of end up decreasing the role of private insurance in financing kidney disease care. And it's really just unknown. Are these payments from private insurance critical to maintaining quality at dialysis facilities? We don't know. And so if this does happen, and it's still, I think, more theoretical, but if it does happen and private insurance sort of funds disappear, what will happen to quality? And then finally, how to pay for new technologies within the bundled payment system, I think, is a big challenge. How do you encourage the development of cost-effective technologies without sort of unbundling the bundle and breaking the bank? And this is going to be technologies around medications and devices. So in conclusion, during the first 50 years of the U.S. ESRD program, it provided critical access to life-saving care for patients with kidney failure. The ESRD program underwent a series of reforms as policymakers aimed to control costs while maintaining quality and access to care. And challenges in balancing cost, quality, and access are going to persist as the program goes into the next half century of existence. So thank you.
Thank you. Any questions? We have a few minutes. Dr. Winston?
I'm thinking about what is in the news, at least what I've been seeing about a lawsuit in California about wages for workers in dialysis facilities.
Mm-hmm.
And so my question is, how much of the costs, beneficiary costs, to run dialysis units are really affected by issues like minimum wage, inflation? So it's a costlier project to treat a patient without any change in what the patient is receiving.
Yeah.
They're walking into the same facility with the same personnel taking care of them, the same dialysis machines, but the costs seem to be going up.
Yeah, so that's a great question. I don't know offhand the share of, like, I've seen it before, but I don't remember like the share of dialysis facility custody that are allocated to wages and salaries, but it's not small. I think this is a problem with healthcare in general, though. Like, healthcare is very labor intensive, and if these sort of tight labor market that we're facing now persists, it's going to be an issue across the board in healthcare. I think dialysis is just, we might be suffering from it sooner and than others, because in dialysis there's been a lot of issues around labor shortages over the past year. And so I do think it's going to be a challenge, like, because like you said, if the wages go up because there's not as much workers, even the same service is going to become more costly. And there are, at least for Medicare, for example, there are mechanisms for accounting for that. They try to look at increasing costs and then build it into the payment system, but there's a lag and there's a delay, and you wonder how well it's going to work. But that's definitely, I think, a big challenge. I don't know the details. I know there's always something going on with labor and lawsuits in California, so I'm not sure what the most recent article is. But this is, I know there's unions and things involved, but yeah, I think this is a huge issue to try to control costs. Again, I don't know if it's specific to ESRD. I think we're at the sort of tip of the iceberg, but could this be an issue across the board in healthcare? I don't know.
Sean?
Maybe I did not hear correctly. Are you saying, are there reasons that are suggesting that a too large chain do not provide as high quality care as the remaining 30%?
I was focusing more on like competition, and so I've done a lot of research looking at market competition and areas where there's less market competition. We did find, like, in one study, more hospitalizations, and after chain acquisitions, there were changes in health outcomes. Again, it was more agnostic of who the actual providers are. I don't know that, there are studies out there looking at health outcomes and chain ownership and things like that. I think they're maybe a little less conclusive. But there's a meta-analysis a couple years ago at looking at for-profit ownership and health outcomes, and that's something people have been publishing on for like 20 years. I guess I was more citing mine, and there's a group at Duke that's done some research also looking at acquisitions and competition and what's happening in markets where there's less competition. I think another big thing about competition, I kind of had a more speculative paper about this because there's not as much research in dialysis. I could find one study written in the 90s on this topic, but I do think a lack of competition could very well hinder innovation. Why are you going to adopt a new technology if there's not, if it costs you money and you're not going to lose patients for not doing it. And so I do think that's another, part of why I brought that up there. It's not just quality, at least theoretically. There's a lot of economic literature about this, how a lack of competition can hinder innovation. And Dr. Bosch was talking about lack of innovation. Maybe that's one of the explanations.
That sounds good, but how are you going to create competition from smaller companies?
It's
making money with dialysis, except
yeah.
Big dialysis. You're buying things, you build up your own thing. How could somebody go back to the model where a physician and nephrologist own the dialysis unit and all that?
No.
That is not economically feasible.
I mean, that's why it's a big challenge, and we could have another talk about overcoming the challenges, I guess. But
That's good.
Yeah.
There's another question?
So, is there any
Do they have any? Excuse me.
any means of
One of the big things I mentioned, the Advancing American Kidney Health Initiative has this ETC model that a third of the country's randomized to. I don't know. I think parts of New York are and parts aren't, because there's multiple healthcare hospital referral regions. But that starts paying more and penalizing providers if they don't meet certain targets in terms of home dialysis. And so I think that's an example. I'm not sure what's going on, if similar things. I haven't heard of anything in private markets following that, although there is definitely interest, I think, in private markets in home dialysis. But that's sort of the big one. And then, if home dialysis is less expensive, so like I had a study a year ago where we looked at costs, just, outside the dialysis treatment, looked at medication costs, and patients on home dialysis were using fewer injectable medications. And so if that's actually true, this was an observational study, but if it's actually true that home dialysis is less expensive, then all of these value-based payment programs that try to keep costs down are at least indirectly creating incentives for it. So that's the other thought.
Okay.
All right, thank you.
Thank you very much. So we'll stop the first session, and we have a lunch break now until 2 p.m., and we're back here at 2 p.m. Thank you very much. So we're now coming to Dr. Jay Wish, who is a professor of clinical medicine at Indiana University. He's a very well-known personality in the field of dialysis with many leadership positions, and he's very well fit to tell us what has actually happened in hemodialysis over the past 75 years. Dr. Wish, thank you very much.
Thank you for the kind introduction. Thank you for the organizers for inviting me. As you mentioned, I'm going to be talking about what happened over the last 75 years, about 45 of which I witnessed personally, but given my aging and my fading memory, I also want to thank Google and my Google searches that went into the preparation of this presentation for refreshing my memory. So here's a couple of disclosures. You can see I have a relationship with DaVita and my primary employer, which is IU Health, which is the healthcare system. I'll talk about what I'm going to cover as well as what I'm not going to cover. The landmark changes in in-center hemodialysis in particular, the technology and our change in the dialysis prescription as a result of some well-controlled and some not so well-controlled trials. The things I will not cover, you can see here, I'm not going to go into peritoneal or home dialysis. I'm not going to talk about drugs that are administered during dialysis, although these significantly impacted the payment, which Kevin talked about. And I'm not going to talk about the consolidation of dialysis equipment manufacturers and the dialysis providers that has also had a significant impact on the way we kind of practice and the environment in which we work. So this has been mentioned a number of other times, and I'm not going to belabor this part of it. William Kolff, who is the father of the dialysis machine, actually did the first machine run while he was in the Netherlands in the mid-1940s. This was a rotating drum, and you've heard it and you see it, and you've seen it in previous presentations. He actually treated a dozen patients with AKI over a 2-year period. What is not well publicized is that only one patient survived. It was actually discharged with normal kidney function, dialyzed long enough to allow that AKI process to resolve itself. Around the same time, in the later 1940s, a Swede, Nils Alwall, invented a dialysis membrane configuration that allowed for greater ultrafiltration. Remember, dialysis is not only fluid toxin or waste product removal, it's fluid removal. And this was a tightly sealed set of parallel membranes, which eventually evolved into what's called a parallel plate or keel dialyzer, and this ultimately became the standard configuration over the rotating drum in the 1950s. And then in 1948, the Kolff dialysis machine was sent to Mount Sinai, and as it turns out, when I did some reading, the hospital administration actually opposed using this in the hospital property, so that Drs. Fishman and Krupp actually conducted the first hemodialysis procedure in the United States at a separate secret site. And then Dr. Kolff ultimately moved to Cleveland Clinic in the 1950s and improved his dialysis machine. So you've seen this picture before. This is the Kolff rotating drum, which is kind of the progenitor of all of our current dialysis machines. And this is an example of the adaptation of the rotating drum, which is now kind of in a steel cylinder, and the membranes rotate inside the cylinder. And this was used extensively during the Korean War to treat AKI among soldiers that suffered trauma, blood loss, et cetera. And whose renal function could be expected to recover because they were young, healthy people with prior normal kidney function, not the necessarily types of patients that we see now with AKI and ESRD. This is an example of the Kiel parallel plate dialyzer. This is an early, cruder example, but you can see basically it is a large frame in which many parallel plates of a cellulose membrane are suspended, and then blood enters and percolates in between the membranes, and then the dialysate percolates around the membranes, and ultimately diffusion occurs. So in the early 1950s, as I said, hemodialysis was used in the Korean War, and this is the time at which 3 times weekly hemodialysis to replace kidney function became the standard of care. Because in these early days, nobody was really sure how much dialysis was enough and how many days a week somebody needed to be on dialysis in order to survive an episode of AKI. And from what I read, and I'm not sure how well this is validated, that they kind of did a trial and error. They dialyzed some of these patients once a week and they didn't survive, and they dialyzed some of them twice a week and they didn't survive, and they dialyzed them 3 times a week and they survived, and they said, eureka, we got it. 3 times a week seems to be the minimum frequency of dialysis that's needed for patients to survive until their kidney function recovers. And it was actually kind of convenient because it meant you could dialyze twice as many patients. You could dialyze half the patients Monday, Wednesday, Friday, and half the patients Tuesday, Thursday, Saturday. So it was good in terms of the utilitarian approach. It was also good for the patient because they gave them 4 days off. So this is how 3 times a week became the standard of care, somewhat trial and error. In the mid-1950s, Kolff moved to the Brigham Hospital and developed what was then called the Kolff-Brigham artificial kidney, which was shipped from Boston to 22 hospitals worldwide. So the dissemination of this technology allowed for greater access to the procedure across the world. But given the need to place 2 central venous catheters to allow for the blood flow that was necessary to do a dialysis treatment, and this required a cut down on each of those veins in which these larger catheters were inserted. We didn't have the Sheldon technique of being able to insert a double lumen catheter then, like we do now. Hemodialysis remained exclusively a treatment for inpatients with AKI. It was not even considered to be an outpatient procedure. So the landmark in conversion from AKI to ESRD came, as you heard before, in the 1960s with the invention of the shunt by Beldix Scribner at the University of Washington, which is well represented at this conference. It was a simple Teflon cannula, one end of which was placed in the radial artery, the other end of which was placed in the brachial vein, and then the device was stabilized with a small metal plate that was attached to the patient's arm, and this allowed for the very first time for ambulatory patients with ESKD rather than AKI to be dialyzed repeatedly through the same vascular access, and ultimately more flexible materials for the shunt were introduced in 1962, and as you know, the shunt was ultimately replaced with the AV fistula. This came in 1966 when Bresci and Semino basically did the very simple procedure of anastomosing of forearm artery, the radial artery, to the brachial vein. Basically, it was like a Scribner shunt, but it was all internal, and this was a much safer way to perform dialysis because you didn't have the 2 exit sites with the external cannula that allowed for infection, and you also didn't have the possibility of an accident where the patient pulled the Scribner shunt loose and bled to death. So this definitely replaced the fistula. So this you've seen before. This is the Scribner shunt. All right, so we've now got repeated access to the patient circulation in an outpatient setting, which laid the groundwork for dialysis among patients with ESKD. Then we have the technology evolution that occurred in the 1960s and 1970s. We always started with the cellulosic membranes, and the question in the 1950s and 60s is, what is the configuration of that cellulose membrane? Is it going to be a parallel plate, or is it going to be a coil, which is basically a large baggie of cellulose that is wound onto itself internally as a spiral and then encased in a plastic cartridge, okay? And this was the dialysis membrane that I learned on when I was a fellow in the mid-1960s. This coil dialyzer was basically inserted into an open tank, and you can see it in this illustration. And actually, it's an evolution from a Maytag washer. Okay, the original tanks that were used for dialysis were actually modified Maytag washing machines. But basically what happened is that they evolved into a specific dialysis container, and the expression bath actually comes from this arrangement where there was literally a bath of dialysate in which this coil dialyzer was inserted, and basically the bath bathed the blood that was inside the membrane from externally, so it allowed the diffusion to occur. What was crude and retrospect, it's almost horrifying that we did it this way, was because this was an open system, it wasn't a single pass system that we have now, there was no way to manipulate the transmembrane pressure except manually by inserting a clamp over the venous return line. So what you did is you increased the pressure within the membrane, and that allowed for a greater transmembrane pressure for greater ultrafiltration. The problem is that you had this loose baggie sitting inside a plastic frame, and if you were a little more exuberant than you should have been in terms of increasing the venous pressure, the whole system exploded. Okay, and this was not unknown that patients who were being treated with these coil dialyzers could have an accident with an explosion. Now, fortunately, the extracorporeal volume was only about a unit of blood, so they didn't bleed to death, but it was certainly a messy situation, and then there was blood all over the place, and I actually witnessed one of these, so this is something that you can't forget. So basically what ended up happening is you had, in those days, 7-hour dialysis was the standard, because this was before the National Cooperative Dialysis Study at the end of the 1970s. And because it wasn't a single pass system, basically the fluid in the tank kept leaching out toxins, urea, phosphate, whatever, and it basically gets dissipated, the gradient gets dissipated after 3.5, 4 hours. So typically in a 7-hour run, the nurses would have to drain the tank and basically put the dialysis on hold for about a half hour, and then refill the tank, add all the concentrated ingredients. They actually mixed it with a rowing oar that you get from like a rowboat. That's how they mixed it all up. And then they would start the treatment again for the second half. Very crude by today's standards, but again, this was what I saw when I was a renal fellow in the 1970s. So in the 1960s and 1970s, we had, as I said, other configurations. One of those was the disposable parallel plate dialyzer. So this is kind of a modernized version of the Keel dialyzer in a single plastic container that, as it says, can be disposed at the end of the treatment. So again, cellulose primarily. It was a smaller extracorporeal volume, which was better suited to children and smaller adults. The ultrafiltration rate was not as accurate as is with the current hollow fiber dialyzer. So to a certain extent, it's kind of a trial and error, and the patient may or may not come off, that many kilograms less than what they went on based on your calculations of transmembrane pressure. But this was the technology of the time. But it was an advance over the tank system because it was a single pass system, so you didn't have to change the dialysate and row it in the middle of a treatment. So really the landmark change in terms of our membrane configuration technology came with the hollow fiber, and Juan kind of introduced this structure a little while ago. So this occurred primarily around the mid-1960s and was ultimately dependent on advances in the manufacturing process for these membranes. So there was the advances in the extrusion technology as opposed to making these sheets of membrane. They were able to make them into capillary tubes, and that allowed for the replacement of these coiled and flat membrane dialyzers with these hollow fibers, the major advantage of which it allowed you to have a much greater surface area in a smaller package. So in terms of the convenience and the ability of nurses to, take them on and take them off, it was definitely a major advance. It also allowed for more precise adjustment of the transmembrane pressure for ultrafiltration because it was a completely closed system, and all of the mechanics of the pressures on the arterial and the venous side were pretty much regulated by the dialysis machine. And ultimately, the mass production of these hollow fiber membranes made them relatively inexpensive, and ultimately, the cellulosic membranes were about $10 a piece. And if you remember from from Kevin's presentation, the reimbursement for dialysis was somewhere around $130. That included what was called the composite rate. So it was economically feasible to take a $10 cellulosic hollow fiber membrane and throw it away at the end of the treatment and then use a brand new one at the beginning of the next treatment. Another change that occurred with the evolution to the hollow fiber membranes was the elimination of acetate from the dialysate. So what the problem was is that you have a concentrated powder or solution that has all of the ingredients for your final dialysate, and then the dialysis machine dilutes it out with purified water so that you ultimately get the final concentration of the dialysate that you're looking for. Well, the problem is that calcium and bicarbonate don't play well together in the concentrated solution. They precipitate into calcium carbonate. So in order to prevent that from happening, the concentrates typically substituted the bicarbonate with acetate, which did not precipitate with the calcium. The acetate would then diffuse into the patient during the dialysis treatment as the substitute alkali, if you will. And then if the patient had a healthy liver and the acetate transfer was not greater than their metabolic rate could handle, that would all be converted to bicarbonate, and the patient would come off dialysis with a relatively normal bicarbonate concentration in their blood. So ultimately, what happened is acetate was not well tolerated. Many patients who got acetate dialysis got hypotensive because of peripheral vasodilation and decreased myocardial contractility. They got cramps, they got sick, and ultimately the development of what's called the dual proportioning systems in the 1970s as a standard feature for dialysis treatment eliminated this problem, because the dual proportioning system took one jug that had everything but the bicarbonate and then another jug that had the bicarbonate, and it would take them up and mix them together with the water so that the bicarbonate and the calcium didn't interact until they were in a sufficiently low concentration, and then you didn't have the problems with calcium carbonate deposition. So again, a relatively simple problem that was fixed with advances in technology. So this is the technology that I dealt with when I was a renal fellow. Okay, we had the CDAC artificial kidney, CDAC Cortistal artificial kidney, cellulosic hollow fiber, and basically this was the workhorse in terms of the membrane that most of the facilities that I went to, both for my day job and my moonlighting job, used. In those days, again, before we had the National Cooperative Dialysis Study, typical dialysis treatment was 7 hours. And since there were limited numbers of dialysis stations in most areas, most or many facilities ran around the clock. So you had a morning shift that went from 7 to 3, you had an afternoon shift that went from 3 to 11 p.m., and then you had a nighttime shift that went from 11 to 7. Well, they needed renal fellows that were desperate for money to staff these overnight shifts, so most of us basically made a little extra money and went to these dialysis units where this was what we saw. What you see on the right-hand side of the slide is the Drake-Willock machine, again, very, very simple by today's standards, purely a mechanical device, zero electronics. You don't see any LEDs on here. You see, old VU meters like you see in the old James Bond movies, before it says danger, danger, and the whole layer of the criminal explodes. But hopefully that doesn't happen with these. And these were so simple that renal fellows learned how to set them up and take them down, and we could run them without a dialysis nurse. That's certainly not true today. So the next landmark was the National Cooperative Dialysis Study. This was published in 1980. And I think as Juan alluded to before, it was really not clear before this study was done what the villain was in terms of making kidney failure patients sick. Was it small molecules that are easily removed by diffusion, or was it middle molecules that are less easily removed by diffusion and easier to remove by either convective clearance or a longer dialysis treatment where you have less competition between urea and the larger molecules to get through the pores of the membrane, because there's just a longer time of exposure of those middle molecules to the membrane. So this was a 2x2 randomized study trying to get at the root of what is the dialysis, or I should say the ESRD symptom villain. And it basically used the time average concentration of urea as a surrogate for small molecule clearance and the duration of the dialysis dialysis treatment as the surrogate. For middle molecule clearance, the patients were randomized into one of 4 groups using this 2x2 permutation. And when all was said and done, what they found was that there was no difference in outcomes based on time, but patients randomized to the lower time average concentration of urea had better outcomes. So this was perceived as a victory for the small molecule toxicity contingent as opposed to the middle molecule toxicity contingent. And it basically meant that long treatments were no longer necessary. That if you could get the patient to feel as well and get the same outcomes with a 3.5 or 4 hour treatment as you did with a 6 or 7 hour treatment, then who wouldn't want the shorter treatment? The patients certainly wanted the shorter treatment, and the dialysis providers wanted the shorter treatment because it meant they could cycle more patients through a station in a given day, and that meant more revenue because their fixed costs were the same, whether or not they had 3 patients in the chairs or 4 patients in the chairs. So again, this kind of revolutionized in terms of the duration of the dialysis treatment. Now, it was a secondary analysis of this study by Gotch and Sargent that looked at KT over V, and KT over V was not used in the study itself. It was actually Sargent and Gotch that adapted what was time average concentration of urea to KT over V using basically first order pharmacokinetics. And what they found is that there seemed to be an inflection point with a KT over V greater than 0.9, patients having significantly better survival than those below. And this ultimately evolved into a standard of care for a single treatment based on 3 times a week, a minimum KT over V of 1.2, which is ultimately incorporated into the 1996 KDOQI guidelines for adequacy. The next landmark was an improvement in water purification. And again, before dialysis became widespread in the late 1970s, early 1980s, nobody was really considering what kind of garbage was in the water that we were using to make our dialysate. And it was thought that dual deionization systems, as well as charcoal filtration to get rid of the chloramines and a little bit of water softening to get rid of the calcium, would be enough to get rid of the culprit ions that might be in the water, because ultimately all water comes from the ground. So anything that comes from the ground is ultimately going to take on a lot of the minerals that are in the ground. And nobody was really worried about whether or not there was too much cadmium or bismuth or whatever else in the dialysis machines. We assumed that the deionization filters were going to take it out. Well, that was a bad assumption. As it turns out, aluminum was a toxin that was in groundwater that was not sufficiently removed with standard deionization systems. And the problem was that nobody really figured that out until the early 1980s, which was about 10 years after dialysis became an entitlement by Medicare. And lo and behold, there were clusters of patients in several areas, Washington, D.C. being one of them, the other being Denver, that I recall the studies, that patients were getting accelerated dementia. And when they did autopsies and brain examinations on these patients, they found that there were excessive amounts of aluminum in their brains, which they attributed both to dialysate aluminum as well as aluminum containing phosphate binders, which were the standard then. And this ultimately led to changes in water purification requirements that mandated the use of reverse osmosis systems, which was not the case before the 1980s. Next thing I consider a landmark is the conversion of the dialysis membrane material from cellulose or cuprophane, which is a copper-based cellulose, to polymers. And Juan again mentioned a little bit about the AN69 membrane, polyacrylonitrile. This was one of the first membranes that was used in hemodialysis as opposed to hemodiafiltration, which is what Juan was talking about. And the problem was that cellulose membranes had biocompatibility issues. They actually activated the alternate complement pathway, and the factors that are released when you activate complement, you know, the B's and the A's and all those things, if you remember your complement pathway, many of those are chemotactic, and they actually cause microleukoagglutination that cause microleucoemboli in the pulmonary capillaries, and many patients will get transient hypoxia during the dialysis treatment. But the more insidious problem with the cellulosic membranes was in fact their lousy middle molecule clearance. And you're gonna say, well, Dr. Wish, you just told me the middle molecule clearance didn't really matter. Well, it didn't really matter in a 6-month study because the National Cooperative Dialysis Study only followed the patients for 6 months, minimum 6 months. But what was happening in the early 1980s, again, you had this cohort of patients that had been entitled since the mid or early 1970s, and 5-10 years, you started to see the end organ effects of bad middle molecule clearance, and that was primarily amyloid. And as it turns out, there were many, many patients reported to have amyloid in the early 1980s, which was attributed to beta-2 microglobulin, which is a middle molecule, and its accumulation. So this basically changed the whole approach to clearance by membranes and pretty much revolutionized the composition of the membranes to shift from cellulose to these polymer membranes, the first of which was the polyacrylonitrile, and then there were other proprietary polymer membranes such as polysulfone that we're mostly familiar with today. That's what the F180 Fresenius membranes are made out of, and polymethyl methacrylate, et cetera. Now, if you're going to use membranes that have higher middle molecule clearance, they will also have a higher ultrafiltration coefficient. So those old dialysis machines like the Drake-Willock that I showed you are not equipped to handle the membranes with high middle molecule clearance, and ultimately you had to have ultrafiltration control machines going with those polymer membranes. So ultimately, this is, again, the standard of care. As I think I mentioned before, the transmembrane pressure was ultimately calculated by the attendant in the old systems, the cellulose system, or by a nurse or technician or whatever, and they actually did a little calculation on their Bomar calculator. It wasn't on their iPhone, because iPhones didn't exist then, and they would figure out, well, how much did the patient gain, and how much do I need to take off today, and what is the ultrafiltration coefficient of that membrane, and then they would come up with a transmembrane pressure through a manual calculation, and then they would set that transmembrane pressure in the machine and hope for the best, okay? And it usually worked, but again, there's human error that you're going to introduce into this process, which is probably not a great thing to do when a patient's life is at stake. So the polymer membranes with their high ultrafiltration coefficients mandated getting rid of this human component, and the original ultrafiltration control machine, as far as I remember, for dialysis was the Hospel Filtrol, which used a volumetric chamber technology, but this was ultimately replaced by the machines that we use today that use a feedback loop technology, which continuously measures the dialysate inflow, the dialysate outflow, the difference being the ultrafiltration rate, and then ultimately sets the ultrafiltration pressure to achieve the pre-programmed net ultrafiltration volume. All right, so when you go from $10 cellulosic membranes to $40 polymer membranes, which is what they first cost when they were introduced, $130 dialysis reimbursement just is not sustainable. So this is how membrane reuse occurred. I mean, it wasn't because anybody was trying to rip anybody off. It was because if you as a nephrologist or a facility wanted to offer the patient the best technology, biocompatible membranes that don't cause amyloidosis, then you pretty much wanted to get the latest and greatest polymer membranes, and you couldn't afford to throw them away. So this is where dialyzer reuse came, okay? So it was pretty widespread, and as you can see, by the mid-1990s, about 80% of dialysis facilities in the United States were doing reuse. It was closely regulated by Medicare surveyors and AAMI, which is the Association for the Advancement of Medical Instrumentation, which came up with all the reuse protocols and guidelines. And there were a number of studies that looked at facilities that did careful dialyzer reuse versus those that didn't, and there was no difference in patient outcomes. So nobody really thought that this was a, pernicious process. So what got rid of reuse? It was, again, economics. Economics drove reuse in the first place, and economics got rid of reuse in the early 2000s when, like plasma televisions, instead of being $40,000 a piece, they're $40 a piece. The cost of dialyzers went down to about $10, and you could afford to throw them away and bye-bye reuse. So then we have another study, which you can see I didn't label as landmark, and that is the HEMO study. But it's an important study in terms of rejecting a hypothesis. All right, this was published in 2002 in the New England Journal. There was about 1,800 patients, again, randomized to a 2-by-2 design. And if you think about the National Cooperative Dialysis Study and the design of this study, you basically say, well, pretty much it's the same study. They just did it again, but they used different surrogates in terms of middle molecule clearance versus small molecule clearance. So they looked at high dose EKT over V greater than 1.45 and EKT over V versus the KT over Vs that we typically measure that are not equilibrated. It's about a 0.15, 0.2 difference. And low flux, which was the old Fresenius F8 membrane, which had a tighter weave, versus high flux, which is the F80 membrane, which is now the F180 membrane, for those of you who are using Fresenius membranes. And again, the high flux membrane is going to have better middle molecule clearance. So again, we're comparing small molecule clearance versus middle molecule clearance, more versus less, to figure out, does this make any difference in terms of outcomes? Follow-up for an average of 60 months. Primary outcome was death, did not differ between the groups. Secondary outcomes, including hospitalization for cardiovascular infectious cause, a 15% decrease in serum albumin, representing anorexia and maybe feeling bad enough so that you don't eat. All hospitalizations not due to vascular access did not differ between groups. So pretty much a negative study, and therefore it didn't change dialysis practice, at least in the United States. And you can see these Kaplan-Meier plots of the patients surviving based on either the dose, KT over V, or the flux, and you basically, again, nothing different. So where does that bring us? What's happened in the last 20 years? And the answer is pretty much nothing, okay? High flux membranes became the standard, and they still are. Medium cutoff membranes are currently being explored for improved cytokine clearance, because now there's a focus on inflammation, and maybe the reason that patients on dialysis don't do well isn't so much because of uremic toxicity, but of inflammatory toxicity. So using membranes that can get rid of more cytokines, may impact it, but again, the jury's still out on that. Hemodiafiltration, Juan again mentioned, it was shown in the article in July to produce improved outcomes in the United States, but it's more expensive and unlikely to get much traction in the United States unless reimbursement changes. Fancier dialysis machines, every generation of the Fresenius model, from the H to the K to the T, they have more bells and whistles, lots of fancy lights and numbers and things like that, but they're all pretty much the same machine. There's more network connectivity, there's more ability to kind of track things over the course of the treatment, but the basic mechanics are still the same. And there was then increased attention to ultrafiltration rate, which I personally think is a good thing. I think over the last 20 or so years, actually since the National Cooperative Dialysis Study, we've kind of been a slave to KT over V, and that's been the focus of everyone on what constitutes an adequate dialysis, to the detriment of the rate of fluid removal. And there have been a number of studies that show a very high correlation with higher rates of fluid removal, with organ stunning and adverse outcomes. So I think increased attention to ultrafiltration rates is a good thing. Whether or not that's actually going to impact on our dialysis prescription and give patients longer treatments if they're high fluid gainers, so we can keep the ultrafiltration rates less than 13, ideally, or minimum less than 13, and ideally less than 10, I think remains to be seen. So the future dialysis, I mentioned this book in this particular slide because, I don't know, raise your hand if you've seen this book or you're familiar with it. It's a very interesting read. It gives the perspective mostly of patients on how evil the dialysis industry is now and has been going back 20, 30 years. I read it, and I don't think anything in there is untrue. I think it's a one-sided view, and it basically exaggerates what a lot of patients who are unhappy with the system have to say. It doesn't go into a lot of the things that are good. But I think if you are a dialysis provider and you take care of patients who are on dialysis, I think it's worthwhile to know what they're saying through this particular book. And that's why I recommend reading it, not because it's gospel. But anyway, what is the future? Well, I think there needs to be more patient-centered care, okay? That the prescription and the setting need to be individualized, how much dialysis they get and where they get it. Again, driven primarily based on patient-centered considerations, not by the fact that Medicare is pushing us to put more patients on home dialysis. A lot of that push is not necessarily driven by better outcomes, it's driven by economics. Metrics of dialysis adequacy need to include both small and middle molecules. The number of treatments per week needs to be driven more by residual kidney function and symptoms, not a one-size-fits-all prescription. The duration should be variable based on also the residual kidney function and the volume status and the comorbidities. Dialysis machines need to be more portable and miniaturized so that patients can, in fact, take them home and use them when they travel. Sorbent systems to regenerate dialysate so you don't go through 100 to 200 liters of fresh water with every single treatment, conserving resources. Sorbent-loaded membrane so that you can actually get rid of toxins without necessarily filtering it out. And finally, individualized dialysate composition. This is a stretch, but I think it's reachable with current technology on the basis of real-time blood testing during dialysis. I mean, if you can test somebody's blood sugar continuously, then the technology is there to test a lot of other stuff, feed back into the system, and get that machine to do what you want. Thank you very much for your attention.
Thank you very much. We have no time for questions.
Okay,
We'll
sorry.
leave it at the end. Thank you very much. So we are meeting again. We're having a break now for coffee, and we're meeting at 3:30. Okay, let's get started. We have another session that is important to start on time so we can finish on time. So this will be a roundtable discussion and will be led by Dr. Sushita Sharma, who is an associate professor at the Icahn School of Medicine here and associate director of the home dialysis program. Dr. Sharma, please go ahead. Sorry.
Thank you, Dr. Irbari. So it's been a great day so far, learning about, from the pioneers and experts in hemodialysis, basically learning about how the first dialysis was performed at Sinai, and then going from there to the road from there to now, where in terms of improvising and innovating, dialysis fluids, dialysis membranes, and dialysis machines. We heard about the changes that have happened in the policies and payments and ethics in dialysis care, and then how dialysis has evolved over the last 75 years. So now it's time to talk about how do we see the dialysis in the future. And there's a lot of innovation and research that has been happening in the field, and let us hear it from the experts here, how we can make it safer, easily accessible, cheaper, and improve the quality of life as well as the clinical outcomes in these patients. So we have 4 speakers for that, and then we will have a discussion about everything. So we'll start with Dr. Michael Rocco, who is the professor and chair of medicine and nephrology at the Wake Forest University School of Medicine. He has been awarded funding for many clinical trials from the NIH and has co-authored over 250 papers. He has also served as a chair of the NKFK DOKI from 2008 to 2023. And we'll start with his talk first.
Thank you very much for that kind introduction, and thank you to the sponsors for inviting me to this historic event. I thought Jay Wish's talk was a nice segue into what I'm going to talk about in terms of home hemodialysis. I'm going to review the past clinical trials in dialysis, covering a few of those topics, with most of the focus being on overnight dialysis, talk about some of the potential adverse effects of nocturnal dialysis, and then talk about how we might mitigate some of those adverse factors. So Dr. Wish's last slide about the future of dialysis, written by my colleague, Dr. Maria from Wake Forest, is a very apropos way of segueing into this particular talk. I remember as a early faculty member being blown away by the study of nocturnal dialysis in Toussaint, France. Observational trial, over 400 patients, and these were patients who went into the dialysis center at Toussaint, France, and did dialysis overnight, 8 hours of treatment, 3 days a week, using 1 meter squared keel dialyzers, the ones that you saw Dr. Wish talk about. And I apologize for the quality of this particular slide, but the way this slide is set up, it shows the survival rates at 4 different centers, going from left to right on the top panel, being from the US Registry, the EDTA, Japan, and Tucson, France. And you can see as you go out to the higher age ranges of 55 to 64 and greater than 64, that the group in Tucson, France had a much higher survival rate than any of these 3 other longstanding programs. And then if you look at duration of dialysis, and this time we're looking at programs going from left to right, Philadelphia, the EDTA, Seattle, Northwest Kidney Center, and Tucson, France, you can see again the survival rates based on hemodialysis duration was very much higher in the Tucson, France experience than in any of the other centers in the United States, in Europe, or in Asia. So the question was why? So as was alluded to before, one of the thoughts is, well, maybe more dialysis is better. So we heard in the last talk about the HEMO study. And in the HEMO study, they looked at both dose as well as flux. And this slide shows that there was absolutely no difference looking at 2 different levels of dialysis, with the high-dose dialysis on average, patients being on session for about 30 minutes more than those in the standard session. So this provoked the question of, well, maybe this wasn't enough dialysis. Maybe we needed more than an extra 30 minutes for 3 times a week. So that led to the development of the frequent hemodialysis trial network. And these were 2 trials that looked at providing dialysis 6 times a week. And there were 2 different trials. This first slide shows you the frequent hemodialysis network daily trial. This was a study that was done in center. The patients had a run-in period where they had to demonstrate that they would come to dialysis 6 days a week and undergo dialysis for 2 to 3 hours. And those that met that run-in period were then randomized to 6 times a week versus 3 times a week. And the dose of dialysis was quite a bit higher than what was done in the HEMO study. The weekly KTORV was 3.5 compared to 2.5 in the standard arm. And these patients dialyzed quite a bit longer, 12 and a half hours versus 10.5 hours. So what happened in the daily trial? Improvement in LV mass, which was statistically significant, improvement in physical health composite score, in the pre-dialysis phosphorus level with a lower level of phosphorus binder use, and also a lower systolic blood pressure. Quite impressive findings. There was also the nocturnal trial. These patients were getting a lot more dialysis than even the daily trial. These patients were doing 6 times a week dialysis at home, and their total hours on dialysis was 30 hours compared to 12.6 hours. But when we looked at the results, pre-dialysis phosphorus significantly improved, pre-dialysis systolic blood pressure significantly improved. LV mass did not quite reach statistical significance, probably due to both the smaller size of the sample as well as the difference in the entry criteria, where patients in the nocturnal trial could have significant residual renal function. But what was most surprising about the trial was the long-term mortality results. Here in the daily trial, we can see here in red that there was an improvement in survival when these patients were followed long-term. And remember, in the daily trial, the patients got 6 times a week dialysis for just 1 year, and then they went back to 3 times a week. So this 1 year of more frequent dialysis carried over in terms of mortality benefit for more than 4 years, with a hazard ratio of 0.54. And that held even when you censored for kidney transplants. So you would think, you know, if the daily trial did better in terms of mortality, wouldn't the nocturnal trial just knock it out of the ballpark? And the answer was no. There was a higher mortality in the frequent dialysis arm than in the standard arm. And that was true whether or not you censored for transplant. What happened? Why was more dialysis worse instead of better? There are a number of different hypotheses that were proposed to help describe this issue. One was, is it possible the patients were overdialyzed? Did they become hypokalemic? Did they become hypophosphatemic? In the nocturnal trial, phosphate had to be added to the dialysate in more than half of the patients in the nocturnal arm. And this was typically done by taking some fleets enema and adding it to the dialysate. Now, there was another nocturnal trial done in Canada called the Alberta nocturnal trial. They, as far as I'm aware, did not report mortality results, but they did a different type of overnight dialysis, which was a single needle dialysis, where the blood pump would move in one direction and then move in the other direction. So the dose of dialysis was not quite as high as it would be in the frequent hemodialysis network trial. Was it exposure to toxins? John DeGeertis suggested maybe these patients were having microbubble exposure. Maybe they were having exposure to some sort of tubing or dialyzer casing component, some plasticizer that was causing this problem. And then finally, there was a question about hypotension. This was an intriguing article that was published just a few years ago, looking at the change in laboratory parameters during a dialysis session. They initially looked at 66 patients, and then in 38 patients, they checked labs 30 minutes after dialysis. And 30 minutes after dialysis, 29% had a potassium less than 3.5, 18% had a magnesium less than 1.7, and 44% had a phosphorus level less than 2.5. So if this was happening with standard dialysis, what was happening with nocturnal dialysis when these patients were dialyzing for 6 or 7 hours and you had to add phosphorus to the dialysate? How low were these electrolytes getting? But another area to consider was hypotension. And if you talk to the individuals who were doing nocturnal dialysis for many years before the hemodialysis trial took place in nocturnal dialysis, you would find that the monitoring of blood pressure during the dialysis session was actually quite rudimentary. What I've copied here is the manual that was used in one of these programs. Obviously, the blood flow rates were lower, 200, 300 mmol per minute. The dialysate flow rates were lower. The maximum UF rates were lower. But what the patients were asked to do is when they started home hemodialysis, they were told to monitor their blood pressure every 30 minutes for a week, and then every hour or two for the next 3 weeks. And then once they were stable, they did not check their blood pressures during the overnight session when they were asleep. The machine would run, and there were certain alarms that would go off, but monitoring blood pressure was not part of what was going on a regular basis. If the patient became symptomatic during dialysis treatment, they were taught how to give themselves some saline. What might be the implication of that? This was an intriguing article from Dr. DeGeertis and his group looking at loss of residual renal function. And here on the left-hand side, we have residual renal function in the FHN daily study. And here we have a measure of urine volume, with the black meaning the patient was anuric and the lighter shades of gray indicating higher levels of residual renal function. And you can see that essentially there's no difference going from baseline to month 4 to month 12 in terms of residual renal function, loss of residual renal function over time. But if you look at the nocturnal trial on the right, you can see that these black bars are much higher on the nocturnal arm than in the conventional arm. These patients were losing residual renal function at a very rapid rate, much higher than what you would see in patients who are doing conventional dialysis. And we know from other studies that residual renal function is very important in a number of different areas. This gets back to what can we do to improve results in overnight hemodialysis. We can do several things. We need to monitor post-dialysis labs. As we heard in the last talk, we need to customize these dialysate solutions so that these patients don't become hypokalemic, hypophosphatemic at the end of the dialysis session. We need more customized prescriptions. We need to monitor blood pressure more thoroughly during the dialysis procedure. Remember that the Tassan experience, it was in-center. The FHN Daily Center study, it was in-center. These patients were monitored on a regular basis in terms of their blood pressure. We need accurate, non-invasive measures of blood pressure. Perhaps we need more AI in terms of algorithms to adjust ultrafiltration rates, blood and dialysate flow rates, depending on blood pressure and other parameters. Where are we in terms of monitoring blood pressures? This is what is used in my institution, the Visi Mobile, which, as you can see, not only includes a wrist monitor, but also several other electrodes that need to be applied. And I can tell you from personal experience, doesn't capture blood pressure very well. But how can you capture blood pressure without using a cuff that's going to keep the patient awake all night and is going to cause issues in terms of quality of life? There are now blood pressure smartwatches that are being developed. This one here on the left, the Omron Heart Guide, actually has a cuff built into the wrist. Apple supposedly will be coming out with a way to measure blood pressure in 2024 with an Apple Watch. Another reason to upgrade your Apple Watch. There's also a BioBeat wrist monitor that uses a PPG sensor. But these are not quite ready for prime time. People are still working on the way to determine accuracy of these devices and to be sure that they measure blood pressure properly. And the European Society of Hypertension has actually come up with a different variety of different validation tests to look to measure blood pressure in cuffless blood pressure measuring devices. So, in conclusion, overnight nocturnal dialysis has the potential to improve mortality, morbidity, and quality of life. But from a technological standpoint, we're not there. We need to adjust dialysis composition in terms of electrolytes based on both pre and post labs, perhaps even modifying the concentration of the dialysate as you're going through the overnight dialysis session. You need to measure blood pressure. You need to adjust blood flow rates, dialysate flow rates, ultrafiltration rates based on blood pressure readings, and do that in a seamless way. And these are all things that need to be done with new technology that is just starting to be developed, but it's not yet ready for prime time. Thank you very much.
Thank you, Dr. Rocco. So our next speaker is Dr. Alfred Chung. He is the Chief of Division of Nephrology and Hypertension and Vice Chair for Research in the Department of Medicine at the University of Utah. He has a wide range of research in hemodialysis and has co-chaired the KDOQI guidelines on cardiovascular disease in dialysis patients as well. So I have Dr. Chung here, and we'll hear from him how he foresees the future of dialysis.
Thank you very much. It's really an honor to come here to see some old friends and meet some new friends. I heard Jay Wish and Juan Bosch talking about, what did he talk about? Coil dialysis and CDEC and Drakewood lock. I'm too young to remember any of that stuff. Okay. Don't laugh, that's rude. Don't laugh, parent. Really, it is intimidating, I have to say, that come in and speak in front of all these experts here, but so take whatever I say with a grain of salt. The good thing about talking in the last session is that everything I wanted to say, you have already heard it. And I am just going to put it in a little bit more cynical terms. Okay, so, all right, let's see. Here's my conflict, but it's not relevant to any of this presentation here. Okay, I mean, everybody has quoted this in different ways. It's difficult to make prediction, especially about the future. So I cannot give you any definitive answer, but perhaps the panel did. Jonathan is speaking last, so ask him, okay, what does the future looks like? So I would there are a few pretty good review of various form of artificial kidneys. And I see that Jonathan is actually going to talk. I'm sure he'll be talking some of this. but I think I only have 2 slides on this, is that artificial kidneys, ideally, the benefits would be continuous dialysis so that you also have cardiovascular stability associated with it. And if it's continuously dialyzing, hopefully you have greater toxin removal and better quality of life. At least that's what we are trying to do, right? So this is the one that I'm guessing that Jonathan is going to talk a lot about it. It's called the WAC, Wearable Artificial Kidney. And it reminds me about 1983. I'm giving it away now. Okay, what am I talking about being too young to remember this stuff. In 83, when I went to Utah, and Dr. Kolf, William Kolf, showed me a WAC. Except in those days, the WAC has to be connected to some source of water. So it's not really wearable. Yes, you can bring it to vacation and so on and so forth, but you better have a water source, like the river or the lake to get your water source. So it's a little bit different, okay? But nonetheless, this generation of wearable artificial kidney regenerate dialysis using urease and sorbents such as zirconium oxide, as far as I can tell, is really very similar to those who are old enough, not me, to remember the Ready machine, right, in the early 1980s, exactly what, and I'm seeing that some of the complication is what we saw in Ready, at least what Jay Wish saw in Ready machine. I didn't see him, okay. But there was clinical trial 24 hours without any problem. The trial was stopped because of variable blood flow rates, and again, they saw carbon dioxide in the dialysis circuit. And that's because of the urease breaking down the urea and generates CO2. So it's the same problem as the Ready machine. But Jonathan can probably elaborate a little more on that. And then we got these fibers being silicone fibers, membrane, and they'll have bioengineer tubular cells into it. I do not know any human study, but the concern here is that you might have clotting, which once you clot, then you gotta have a surgery to get in there to remove it or change it. And there's also concern about renal tubular cells viability. The next one, very briefly, is about iPS stem cells, making organoids, but as far as I've read, is that these do not mature beyond the equivalent to second trimester of the kidney, and then using kidney on the chip. I have not seen anything about that it's being used as a clinical trial. So here is the WAC. This is the circuits that you see. This is one probably the closest. Jonathan is involved in this. He'll tell you more, but it's probably the closest to one of these days in clinical use, but I do not think it will be very widespread use in the near future at least, okay? But it's the closest among all those. But this is the picture that I got from the JCI Insight picture. It is not trivial, right? I mean, it's not like an Apple Watch that they're talking about. It's quite a bit of armor there you're wearing, okay? So how does all these various forms of dialysis compared to various types of transplant, whether it is porcine transplant, other forms of transplant? I think it's a race. We can talk about who's going to win, but I don't think it's an easy call. But I think there's some of these, for example, the WAC, I can see it being used in a limited number of patients sooner than a lot of these transplant using other organs from other species. But I cannot predict the future, okay? So I will hear from all of you about who is going to win here. So, but in the short term, I think that's a little bit easier for me to guess. I still cannot predict for sure, right? We have been changing from technology advance to systemic medical complication for a while now. That's what the emphasis has been in the last 20 years or so. There are still technological advances, But for example, I think vascular access, I don't want to be too self-centered to talk about it, it's still very, very important, right? Even you use the WAC, still gotta be a reliable, durable vascular access. So research in that area still needs to be going on. But what are these medical complications we are talking about? The emphasis, anemia, we have more mineral bone metabolism. I'm still bugged the heck out of me about phosphorus. We can talk about it all day long. I go to McBride and dialysis unit, it's still phosphorus, phosphorus, phosphorus. Right? But the two things I want to emphasize still, I think it is cardiovascular disease and the uremia and the diabetics. Both the heart and the blood vessels are still very problematic, and fluid, sodium. Blood pressure, we don't know what we're doing with blood pressure in dialysis yet, at least for intermittent hemodialysis, right? We don't really know. So these are two areas I highlight in yellow because I still think needs a lot to be done. So there is, besides the technology, which I agree, I think it's Jay to say that, although I am a little bit slightly more optimistic than Jay, I think that there's still things going on. But I cannot argue with him that we are fine-tuning to some extent, okay, about a lot of the technology, to some extent at least. But quality of life, I'm not going to get into. This becoming more and more important, patient-centeredness. I do believe that because of the pressure that I would expend upon it, the last 3 to 5 minutes of my talk, is that we are pressured probably by ETC, by any other model, or technically what is realistic for the patients, or for the population. I think home dialysis will continue to gain momentum. Increasing dialysis time, I don't know how much time is too long. Okay, I am obviously surprised by the result that Mike Rocco told you about nocturnal dialysis. But the national time for 3.5, 4, I have very difficult time to get my dialysis unit to go much over 4 hours still, right? I would love to get them to 5, 6 hours and more frequent dialysis. I believe that, well, 30 years ago, if I used the term middle molecules, you guys either boo me or just walk out, okay? But I think it's gaining a little bit more acceptance. Hemo study, EFIC-Gen, about, and the more frequent, the hemofiltration study that you hear, several of them, the one published months ago in England Journal. I think we are gaining some momentum. I truly believe there's no question middle molecule exists, including FGF23. It's a middle molecule, whether you like to call it or not, right? It is, I think that is more and more important, knowing that both molecule and middle molecule clearance are important. The global cost is what I want to finish off at the end of my talk here. I apologize for being a little bit cynical, but be prepared for that. And we're going to deal with it with regulations and probably financial disincentives. So we have already seen this, right? That life expectancy keep going up in the US, probably because of the feature that I will show in 2 slides, right? But life expectancy is going up, and consequently, you have higher incident count and higher prevalence count of ESRD, right? So we already heard that, better survival from diabetes, cardiovascular disease, and other organ diseases, but I'll show you the next slide to elaborate on that point, and resulting in older age and higher comorbidity in dialysis population. So I made up this slide talking about competitive survival among different organs. Everybody is making advance, right, that we cheer, okay? The lung people, the liver people, what is that one? There's a cancer cell, the infection and vasculitis and so on and so forth, right? Everybody's making some progress. We like to be, I'm nephrocentric, the kidney is number one. Well, we get RAS blockade, we get SGL2, and we get aldosterone inhibitor, and the cardiologist say, hey, those helps us as well, right? We get dialysis, hey, we get LVAD, okay, right? So we would like to be king, we will probably be king, we'll keep the patient alive. Whatever you guys do, we'll take care of them, okay? We'll keep the patient alive, send it to Jay Wish's clinic, right? Well, what we have is that we win, great, we win. We keep the patient alive. but we are also left to pick up the pieces, right? So the thought is that you would end up a typical patient, hemodialysis patient who was 100 years old with all organ diseases, not necessarily failure, all organ diseases, right? That's just the nature of medical care. Everybody is making advances. The patient living longer and longer with comorbidity, unless everybody die of sudden death all of a sudden, right? I mean, otherwise, you're gonna have a lot of comorbidity. I don't know how to solve it. Maybe Kathy can solve this for us, right? It is a difficult problem, but I think that's what we're dealing with. So I think the future of dialysis, the next 10 years, unless we really have one of the WACs and one of the renal tubular cells device really coming into play, we are going to deal with a very difficult problem with taking care of patients getting older and more comorbidity. And that is the economic burden, right? So I'm going to stop there. It's a little bit cynical, I apologize, but I think that's what we are dealing with. Thank you very much.
Thank you, Dr. Chung. Now we have the next speaker, Ms. Kimberly Davis. She is a nephrology registered nurse for the past 28 years. She has been very active in the home dialysis for many years and is currently the director for home therapies at the Rogosin Institute in New York City. So we'll hear from her what she thinks about the future of dialysis from a nursing perspective as well as from home dialysis perspective.
Good afternoon, everyone. I'm very thankful for the faculty of Mount Sinai, Dr. He, Dr. Urabarri, Dr. Sharma, for inviting me to come speak to all of you this afternoon about my passion about nephrology nursing. Actually, today, I actually brought one of the original copies of the first HICFA report for New York, which was the paid aid demonstration, which was done at, I see someone's head shaking. It was one of the first papers written into the healthcare finances and saving with dialysis in regard to staff assist dialysis, which actually increased rates of home dialysis over 78% in the New York area, as well as other areas. So when they said the Odyssey of dialysis, I honestly thought I was invited because I was one of the exhibitions today and being in nephrology in 30 years, but I actually found something that was a little more dated than myself. So in my objectives, because I only have 15 minutes, which if many of you know me, I could talk hours on hours upon nephrology nursing and particularly home dialysis, is to discuss the role of the evolving nurse in patient shared decision-making and treatment options, discuss emerging technology and what presently holds us back, as well as what is in our future, and also discuss nurse empowerment as necessary to bring nephrology to the forefront. So patient needs and opportunities, I feel from what I've seen that nephrology nurse is definitely evolving because it changes in the space that you work, and it's not essentially because you're an in-center nephrology nurse or a home training nurse that there's different needs our patients have and there's different treatments they're receiving. And while a nephrologist may be focused on what we consider to be the top tier or more critically important aspects of treatments, nurses are evolving into becoming preventative health maintenance managers, case managers, and also becoming patient allies in order for them to have the quality of life and the outcome on dialysis that they expect. One of our home patients in our nocturnal home hemo program has been in our program for over 22 years. He is one of the original nocturnal home dialysis patients who's in our remote monitoring program, and I asked him, I had a phone call with him in putting together this presentation, and what he felt, how the space was saying, and he said by being a patient ally is definitely a key to being constantly listening to your patient and saying the treatment is working or it's not working, and we're not looking at the patient on the basis of a flow sheet or a physical number, meaning KT over V. So we're moving toward a model of more rehabilitative models in order for patients to be successful and also be rehabilitated along the process. So there is definitely an opportunity for self-care. This is not a new model. I'm sure a lot of physicians in the room here have experience with large self-care units, and particularly in Mount Sinai. I know at Cornell and Rogosin we had an entire floor of self-care that happened 20 years ago with patients feeling empowered to either do their dialysis in center or actually at home. I've done some historical research on the numbers of patients that were between Mount Sinai and also Cornell or Rogerson, as well as SUNY Downstate, which actually in very early years in the early 1980s had more than 100 patients in each one of their programs. So we're never looking at anything that is a brand new technology, and that's what I want to emphasize to nurses, is that these are rather old ideas that are coming out of the closet, but it truly for the increased focus of the transitions of care rather than the delivery of a treatment. So with emerging technology and what holds us back, at the Rogerson Institute, we also do a lot of research. I had to use this diagram because I probably have signed about 10 different NDAs in the last 2 years and cannot show actual pictures of the emerging technology that is coming. But from the left-hand side, but what we talked about was single pass dialysis going into more implantable or wearable artificial kidney options, and also employing on research that has machines that will be decreased down to the size of a suitcase. Many of you are familiar with a physician from Brooklyn who actually in the 1950s actually developed a dialysis machine that was the size of a suitcase that will be more durable, more portable, and better for patients as far as not utilizing the amount of water, and also employing things like sorbent technology, which we just heard about as well. So I'm very excited because I grew up through the entire alphabet of Fresenius machines, starting through A and ending with T, and also was the third nurse to use NextStage in the country in New Jersey, as well as with the Rogerson Institute being the first institution in the entire country that put patients home on the Tableau system. So I could say that I work in a very enthusiastic organization that we like testing out technology, but some of the problems or challenges that we have with a lot of the equipment, just moving forward here. And I won't be withholding any information. Is what I always say, I always speak with honesty, but it is also the patient adopting a self-care mindset, in that nurses are enormously important in patient activation. And this is something where there's been very little research on, but is definitely motivating a patient in order to feel confident to choose home dialysis. And even in some cases, know that they can confidently do their dialysis alone by themselves. We do have solo dialysis options available. One of my challenges, and particularly in the New York area, and particularly in Brooklyn and other underserved areas, is that homes are not sufficient or capable of handling home dialysis. You have people going through rough economic times with multiple people living in their homes because they do not have the finances and may live with 4 or 5 different people or family members, or being uninsured, and as a person be very capable of doing at-home dialysis, but the structure of their home, the equipment is lacking in connections and ways to connect this equipment, even in things like NYCHA housing. We still haven't found a suitable machine to plug in easily in there. Supply burden, patients do complain about having home dialysis supplies in their apartments, whether it be a studio apartment or in their homes. I had several patients that converted from one therapy to another because they were talking about the walls closing in on them with the amount of supplies they had in their home despite biweekly delivery. And I think that's unfair to a patient to, tell them that you should tolerate this because, you're feeling better, but because you've got 70 or 80 boxes in your apartment, you can just deal with that. I think that future equipment needs to be better in reducing the amount of supply. I know a few of the machines actually recycle or do not need a water connection, which is transformative for dialysis, which you will see happen within the next 5 years if this technology increases. Patient access and racial disparity, plus insurance challenges to allow access. I was talking to Yvette earlier, and I said some people think, well, how are we going to access more patients? And insurance companies definitely disallow patients from going to regional training centers. And that's the way the system was back in the 1970s and 80s, is that a lot of the people who were really experts in home dialysis were regional training centers. Patients could move easily back and forth. And there are a lot of challenges along with insurance companies these days, because patients who may come to me if with interest in home dialysis, I cannot service them because they possibly have insurance contracts that are with other hospitals, and that disallows nurses and nephrologists who are experts in home dialysis from reaching more people to increase those numbers. So, like I said, what is improving? The future technology is smaller and movable. I said in the future that I have seen, as being a future seer and an NDA signer, of equipment that will be suitcase size and able to roll in and out of a closet for a patient, be much lighter to move around. Devices that will not require water hookups, along with sorbent technology to not require a patient to have a water connection in their home in order to do home dialysis, and I feel that that would be a game changer. Nurses may also lead nurses on critical research projects to help develop new technology for patients. In my career, I've been part of 5 key mechanical, I wouldn't say experiments, but also research projects that have been for home dialysis equipment. I've also done device research for non-connected Bluetooth blood pressure cuffs, is a different one that we were using in our facility. I think these types of technologies will also change the in-center of environment, especially with the wireless blood pressure cuffs, in order to monitor closely patients who may be having arrhythmia or other adverse events during dialysis, meaning that you will see something kind of like a critical care monitor sitting in the dialysis unit who is watching trending blood pressures. And on a continuous blood pressure monitor, you can see a lot of other things other than a snapshot of a blood pressure, and even preemptively stop a hypotensive episode. So that's pretty exciting. Sorry. So as nurses, I think there's some obligation that all of us have, is to empowering nursing through leadership. A lot of us, like I said, I've been in nephrology for 29 years. I'm not going to disclose my age, but at this point I started very early on, but I've also had a mental idea or a belief for my entire career that we are here to train the next nurse and empower the nurse to have your expertise and knowledge to bring them through. One of the things that I have been waiting 29 years to say in my career with home dialysis is that home dialysis is an expert specialty. I don't think home dialysis nurses are recognized to the level of the ICU nurse or other hospitalized nurses that have a different work capacity but have a different relationship with their patients that is not recognized in the nephrology community. And they're an important piece of what will bring nephrology forward in the next 10 to 15 years, are nurses that specialize in home dialysis. And as more developments in home dialysis happen, so will the importance of this kind of nurse. Ooh, that felt good to say that. I worked in community hospitals. I've never worked for a large dialysis organization. I preferred working with large dialysis or independent organizations because the nephrologists I work with allowed the nurses a lot of autonomy to be creative. And these things, in working with the teams that I have and that you also have at Mount Sinai and academic institutions, will definitely lead to the future of nephrology. Leadership roles in emerging and evolving programs will require mentors with a high level of expertise. In our home dialysis program, we have even taken higher levels of acuity in patients that you would probably think were LTAC patients. So we've done LVADs at home. We have a little checklist of each type of patient that we want to try to bring home. We've had patients that were rehabilitated off of ventilators post-COVID, still required dialysis, and brought them home. So I feel that your program has to challenge itself to take on those different patients, because the success of taking on these patients has, I've seen, led to patients, up and walking where they were basically debilitated, and the wife did not want the person to stay in a rehab facility because they made a medication error. And the patient required ambulance transport back and forth to dialysis. And I work for a nephrologist. If you do not know Dr. Franklow, you should meet Dr. Franklow. And all of us got together and said, we're going to do this, no matter what it was. The patient was critically ill, and at that point, we decided that the patient would be put home on staff assist for a period of time rather than ambulance transport back and forth, because that was over $2,500 per ride back and forth for this individual. So we did a process of 3 weeks of staff assist support and then support in the home. And within 30 days, this patient was up and walking out of a wheelchair. We have also had patients in our program, due to technology advancement, especially with the Tablo machine, that have bilateral amputee and do all of their dialysis themselves, because the unique thing about that technology is that you can sit in front of it, and it doesn't require you to have 2 legs in order to set up your dialysis machine. So luckily, we've been able to offer therapy to patients who we thought could never. We also have a wheelchair athlete in our program who sets up the next stage machine and does solo home dialysis. I have taken patients on from Eastern Pennsylvania who the LDOs will not allow them to do solo dialysis at home. And I've personally driven out to Pennsylvania to what I call loop the wagons, do the recall. That's why I own a Jeep. And I've had patients come to me for technology as far away as Fairfield, Connecticut, and I've personally driven out to their home to transition them onto equipment. And that's the way I live my career, and a lot of people who know me for that. We have to create environments to allow nurses to innovate. Sometimes let's do it needs a little hand-holding, but can lead to a phenomenal patient outcome. In the future, you will have to have these strong teams in order to make future advancements in nephrology. I always say this: be the change, embrace the change, and love what you do, or work with someone who does. Thank you very much.
Thank you, Ms. Davis. So the next speaker I have is Dr. Jonathan Himmelfarb. He's a professor of medicine and director of Center of Dialysis and Innovation at Kidney Research Institute in the University of Washington. He has held many important positions in various national and international nephrology societies, including past president of ASN in 2014 and 15. So here, without further ado, Dr. Himmelfarb.
Thanks so much for the introduction. And Kimberly, that was an amazing talk. It's really hard to follow that talk and what you do. Thank you for what you do. It's really, really important work. I entitled this Solving Engineering Technology Challenges to Transform the Future of Dialysis in 10 minutes or less, or about. And Jay Wish said earlier, not much has happened for the last 20 years, if I can quote you correctly on that, from a technology perspective. And I think it's true that if you compare what's happened with LVADs, or you compare what's happened with the so-called bionic pancreases that have been developed that are now patient-centered technologies, we haven't done that in the dialysis field. And there was a lot of incredible innovation back in the 1960s and 70s with these pioneers, but it really hasn't been the same since that point in time. These are important disclosures because they're relevant, that the work that I'm showing today, which was all done at the University of Washington, we have spun out a company to commercialize these technologies. So one of the nice features of being the last speaker is you can revise your slides all during the meeting. And there was a lot of talk about Willem Kolff. So I put a few slides in here about Willem Kolff, who was utterly remarkable. There's a biography that was written about a year ago. It's worth reading by, I forget the guy's name, but he's a Dutch author. But what he did in the midst of World War II as a physician, working essentially under an assumed name, having fled the Nazis in a hospital in the Netherlands, and in his basement at night building dialysis machines. And as I think it was Jay said, the first 16, I think was patients, all died. He wrote a book, Willem Kolff did, that he self-published. He made 25 copies and he gave them to his friends. He put inscriptions in and gave them to his friends. And I got a hold of a copy once, read the book, and this in the entire book where he meticulously wrote down what happened with every single patient that he treated. This is the only experiment that he ever did. He never did an animal model experiment before doing human, quote unquote, human trials. And he wrote, when I took a piece of cellophane tubing, which is essentially the same cellulosic material that was used for a while in dialysis, artificial sausage skin, put it in a water bath, put 400 milligrams % urea in the blood inside that cellophane tubing, shook it up and down, to my surprise, saw that in a period of 1 minute, most of the urea had been removed. And the next sentence, he says, I decided that if I could remove from this patient just as much urea as he formed every day, that he could live. That was it for experimentation. IRBs today might have a little bit of an issue with this, but this was the pioneer. But the things that struck me about this are that he focused on two things: diffusion, a semi-permeable membrane, urea diffusing across a semi-permeable membrane, and urea as an indicator solute. You fast forward 80 years, and what we're doing today isn't a whole lot different than what Willem Kolff did in the 1940s. He also said in the 1960s, and Belding Scribner had a similar quote, the other pioneer, they were sort of joined at the hip in many ways. They both won the Lasker Award together. If we're going to keep patients, and let me emphasize the word we, if we, and that's our community in this room, are going to keep patients alive by artificial means, we then incur the responsibility to see that it is a good life and an enjoyable life. So we have that responsibility, and Belding Scribner said something similar and said, if patients are not fully rehabilitated, then the treatment is inadequate around the same time in the 1960s. And I would submit that our treatments are still inadequate, and for most patients, we don't see that they have a good and an enjoyable life. Willem Kolff also embraced the idea of portability. As most people know, he died in his late 90s. He was a pioneer, an entrepreneur, an inventor, not just in dialysis, but Alfred's from the University of Utah, where the Jarvik was a trainee, and Willem Kolff really essentially invented the artificial heart as well. He understood that dialysis should be portable and should allow patients freedom to live their lives the way they want to. And this was mentioned that he did invent a quote-unquote wearable artificial kidney back in the 70s, and he took patients rafting down the Grand Canyon at that time. You can see by the outfits in that middle figure, it's kind of circa 1970s. But he never solved the dialysate problem, as was mentioned. So you had to bring in to the Grand Canyon 20-liter bags of dialysate for the treatment. That's the part he could never solve. And we in Seattle were fortunate to have an incredible patient who unfortunately died a few years ago, who was really an inspiration to a huge community. Bill Peckham dialyzed himself at home for 29 years. He dialyzed himself in almost 30 countries. He started a blog way before blogs were popular for patients called From the Sharp End of the Needle. He was the first patient to be the chairman of the board of trustees of the Northwest Kidney Centers in Seattle. Really an amazing person, and he used to say, we as patients don't live to dialyze. We dialyze to live our lives. And he would say, live the life you were meant to live. And this is a picture of Bill rafting down the Grand Canyon, recapitulating many, many years later that Willem Kolff trip that patients took. with a next stage machine you can see on the raft here. But he also had a physician and a nurse on the trip, and it took about 4 months of meticulous planning. So Bill Peckham did not get to live the life he was meant to live, even though he lived an incredible life for somebody on dialysis for 30 years. But he inspired us to start the Center for that and the study. I'm not going to show the slides. Alfred showed them from the clinical trial we did under the auspices of the FDA Innovations Pathway 2.0 of Dr. Gorer's wearable artificial kidney device. I stopped that trial. I was the lead of it and stopped it for safety reasons about halfway through because I had a lot of concerns about the device. But it was conducting that trial for me was a light bulb moment because I had patients from around the world, around the country, emailing me and their families. And to this day, I still get emails saying, can I have one of those wearable devices? My father, my uncle, my brother, somebody needs this kind of device. And the second thing from conducting the trial was the realization that if we're going to do something like that, we need to improve from a technical standpoint every aspect of the dialysis circuit. Because everything has been designed to simply get through a 4-hour treatment and be discarded after that. So we started a Center for Dialysis Innovation after that trial at the University of Washington, which I co-founded and co-direct with one of the world's leading biomedical chemical engineers and material scientists. So it's a pairing of an engineer and a nephrologist to see if we can reinvent dialysis technology. And what I would say is the future, and we just heard this, I think, from Kimberly Well, is home-based and on the road. That dialysis is going to have to be portable in the future, maybe wearable, but certainly portable, and not need to connect to a water system to enable patients to get the treatments they want. It has to be environmentally sustainable, use a lot less water, not have infection risk, and it is fortunately now being incentivized top-down by government, by payers, by patients who are becoming far more active in demanding that we as a community do something for them. And I put this slide together just to point out the growing concerns about the environmental non-sustainability of dialysis today, particularly about water usage around the world. By my calculation, we use about 300 billion liters of high-quality water for dialysate around the world these days every year. That's not sustainable. And a couple of years ago, I used to say that in Aboriginal Australia, where the Aboriginal population has high rates of kidney failure and it's the desert, they were having trouble getting people dialyzed. But we may be talking about Phoenix, Arizona in a couple of years the same way, where the Colorado River Basin is disappearing. So water is the big issue. Kimberly set this up very well by saying, people at home, if you want to get people home, you can't medicalize the home. That was something else Bill Peckham in his blog used to talk about, was medicalization of the home. And he had a picture in his blog of a house filled with supplies, basically taking over the entire home, plus the plumbing and everything else that goes on. So the question is, this is the question we set ourselves and about 50 world-class engineers at UW, fueled by, I should say, a grant, a 5-year, courageous, visionary, $15 million grant from the not-for-profit Northwest Kidney Centers, essentially founded by Belding Scribner and his colleagues, to transform dialysis technology. And we told them, we don't know how we're going to do it, but we will give it our best try. So we then said the number one problem to teams of civil engineers, mechanical engineers, industrial engineers, bioengineers, chemical engineers is, can you help us create a regeneratable closed loop of dialysate that we can detoxify but leave the electrolyte composition relatively intact in real time as it circulates, so that we could do an entire dialysis treatment on 1 to 2 liters of water. And we had a whole group of engineers come up, and we told them, I got up in front of a room this size, it was full of engineers when we were starting this, and I went through the whole history like we have today of what we do. 2 hands went up. First person said, do you mean to tell me that in 2017 you're still relying on diffusion to get rid of solutes? And the second hand that went up, an engineer said, my lab is using, we are oxidizing urea to generate energy to power our microfluidic devices. So I thought, okay, they think differently than we do. And basically I said, imagine Willem Kof and Belding Scribner had respectively been hit by buses, and you were tasked with inventing a treatment for uremia using 21st century materials and 21st century engineering. How would you go about it? And we seed funded for the first couple of years a number of really innovative, really clever ideas. And then one idea really came to the fore, and that's the one we have followed up on. And the inspiration from this came from self-cleaning glass. Self-cleaning glass, you know, these high-rise buildings, got a lot of them here in New York City, that people want nice views. They don't want organic matter from the atmosphere blocking their view. Self-cleaning glass was commercialized right around the year 2000, and basically it's a thin coating of TiO2, titanium dioxide, is put on the glass, very thin coating. And then with sunlight, which is UV light, as the energy source, TiO2 catalyzes the oxidation of almost every kind of organic molecule. And that's all self-cleaning glass is. So we thought, if you can catalyze the oxidation of any molecule, how about urea and various uremic toxins? We went to the literature. It had been tried, never tried for dialysis. It had been tried for environmental cleanup in soil in the 1960s and 70s, but abandoned because it wasn't very efficient reaction. And we went through all the calculations, and it was nowhere near efficient enough to be used for dialysis. But we realized that if we could oxidize urea with TiO2, we can produce CO2, nitrogen, and water, and CO2 nitrogen can be degassed. All those old Ready Alliance systems that I used actually as, even as an attending, not as a fellow, so I'm dating myself a little bit, used urease. And the problem with urease, it's not a sorbent, it's an enzyme. You have to combine urease with sorbents, but it's an enzyme, and unfortunately, urease breaks urea into ammonia, not nitrogen that you can degas out, and ammonia is toxic. So then you had to have massive quantities of zirconium phosphate as a sorbent to take out the ammonia, and when you did that, you also took out the other cations, so you had to replace all the other cations, and you ended up with a system that was bulky, expensive, and couldn't compete basically with RO back in the 1970s, when the Ready was used, though, in Alliant for treating several million people successfully. So we have the advantage with photooxidation that that's not a problem. So long and short of this is that we built this into devices and showed it can work, and showed it now robustly that we don't produce any ammonia at all. We don't oxidize things like chlorine. We can regenerate dialysate, and what we envision is a device where you can run an entire treatment on a 2-liter prepackaged bag of sterile dialysate, which also gets over some of the problems even Tableau, for example, is having with tap water, variation in tap water, et cetera. I'm getting one smile at least. Yeah. So there are huge advantages, but the big advantage really is that it takes the water system out of dialysis. And this is an example, just a benchtop, what we did with a 40-liter vat. We fill it with 10 millimolar urea and infuse another 15 grams of urea over 24 hours into the vat. And we set it up with our device, and if you don't turn on the LED light, then nothing happens. And like a patient who doesn't get dialyzed, there's continuous increase in the blood urea concentration, 40 liters emulating the total body water of about a 70 kilogram person. But if you turn the light on, then the urea stays constant over the 24 hours. So you really, truly can maintain homeostasis. And then we've moved this, we've increased the efficiency another 5-fold recently and built it into a, looks much more like a real dialysis device that integrates all the components. This was a picture in the journal Nature from March of 2023. And Kimberly already set the stage that we think that we can make a portable suitcase device that'll weigh 35 odd pounds, and will not need a water connection and can do dialysis on a 2-liter bag of prepackaged sterile dialysate. So that is what we've been working on. But the first thing we did actually in the Center for Dialysis Innovation when we started it is create a patient advisory board. And nobody has ever done this before, but we basically integrated knowledgeable, articulate patients as a design team and integrated them in with the engineers to design the devices that patients want from the get-go. And one of the things I learned from patients is that as much as an impediment of medicalization of the home with supplies and plumbing is, a similar level of impediment to home hemodialysis is that no patient likes, in fact, I would say they despise having to stick themselves or having a loved one stick themselves with 2 large bore needles 3 times a week, never knowing if they're in the right place and the access is going to work. So our patients told us that if you're really going to make this work, you also need to completely re-envision what dialysis would look like, and this is what we want. It's got to be touchless, there's no needles, no biofilm, no fibrin sheath, heals into the skin, resists clotting, prevents infection, and you can build in sensors and controls. I often say my coffee maker, which only costs $19.95, it's not a fancy coffee maker, has at least 2 sensors. It doesn't start percolating till the water reaches a certain temperature, and it doesn't turn on till you close the lid. There's a light sensor in it. That's 2 more sensors than we've ever built into what's supposed to be a life-sustaining medical device for hundreds of thousands of patients. And if we build sensors in that continuously sense the blood, then as others have talked about, we can adjust the treatment based on what patients really need. And patients can provide their own dialysis based on what their needs are going to be. So the question is, how do you do this? And what we did is we sent our human factors team into the dialysis unit to watch what happens. First of all, I think wearable and portable forms of dialysis cannot use arteriovenous access. We started with that as a presumption, because if somebody's riding a bike on dialysis or who knows what they're doing, crazy something, and they get an arterial disconnection and exsanguinate, you just can't do that. So it's going to have to be veno-venous access for any of these portable forms of dialysis. So that was the challenge from patients. We sent our human factors team in, and they watched, and they were amazed at what happens every time you connect or disconnect a catheter. And I didn't bring them here, but we have made movies of the 50 steps, the amount of what people do without even thinking about it most of the time in connecting or disconnecting a catheter. And they watch what happened in the dialysis unit. And there are about 50 different steps and all kinds of disposables in connecting a catheter and about 40 to disconnect it. So we came up with this idea of a fluidic interconnect interface between the machine and the patient. And it's computable, and it will automate the connection and the disconnection to dialysis. And it'll be about the size of an iPod, the iPod holder for the earpod things where you flip it open and you take out your earpod. A little bit bigger than that, I think. I will say I was extremely skeptical when this idea came up. But we built a prototype, and the fluidic interconnects work, and we built a computer program, and it works with the fluid interconnects. Now it's a question of miniaturizing it, figuring out sterilization, et cetera. And this reduces the number of steps from 50 to 14 and 38 to 11, but more importantly, you eliminate virtually every touch point of the catheter and every potential for human error. And it's much faster, and you don't have the disposables. So we took this, I didn't put it in here, but we took the slide, we took the demo into the dialysis unit, showed it to patients, staff, nurses, physicians, and they all said, oh my God, how come no one's done this? We would use it on every patient who's on a catheter. It takes half the time that it does to manually do it. Staffing is a huge issue, especially around turnovers and transitions. And patients thought this was fantastic. So those are 2. We have others, but I was only given a few minutes of innovations that are trying to create an eco-center of innovation to really transform what dialysis will be like in the future. So I didn't work on this with Alfred, but this is my last slide. Alfred attributed this quote to a Nobel Prize winning physicist from Copenhagen, but we're in New York City, the Big Apple. So it has been attributed to Yogi Berra as well. So none of us know what the future is. And as Kimberly said, it's now exciting that there are a number of innovators out there that are, for the first time, really working on different solutions, and I hope that somebody, we or somebody, comes up with much more patient-centered solutions for dialysis in the future. And that is the last slide.
I would like all the speakers to just come over here for the discussion and questions. And we'll take questions. Yes, ma'am.
Thank you very much. One question I had, you showed sort of how you can clear the urea, but classically taught that the urea is, a marker is not dangerous. So I guess if there's a way, like how does that system clear the middle molecule, the other toxins you don't know about, and then does it regenerate things like acid? How do you clear potassium, like that system?
Yeah, great question. So, we focused on urea because urea there's quantitatively so much more urea generated each day than any other toxin. Most of the, things like indoxyl sulfate, paracresol sulfate, whatever, you're talking about nanograms per day or micrograms per day. You're talking about tens of grams of urea. So the reason you need such high dialysate flow rates is to keep the urea concentrations very low in the dialysate, so you have a continuous gradient across the membrane. There are lots of ways to solve removal. First of all, the photooxidation will oxidize a lot of the other organic, if we need to, uremic toxins. But you can also put charcoal, activated charcoal, into the circuit, and we would, and that absorbs a lot of middle molecules as well as even the lower molecular weight toxins like indoxyl, paracresol, lots of others, phenol, acetylglutamine, et cetera. So there are strategies. If you can solve, what we thought is if you can solve the dialysate water problem, the rest of it's easy, relatively speaking. And we will use sorbents, but they'll be very targeted to sodium removal for sodium balance, which is going to be very important. We would probably UF 2 liters into the same 2-liter bag that the dialysate came from, and that removes a lot. Basically, you shift your thinking to now, how do I maintain mass balance? Not how by the end of the treatment do I get from this super high level of everything that accumulated over 48 to 72 hours, but now, how do I maintain mass balance on a daily basis for phosphate, for potassium, for acid generation, which is about 1 milliequivalent per kilogram per day. You're going to have to either replace with bicarbonate or have another solution, a sorbent that binds hydrochloric acid. But most of the problems with the previous sorbent-based systems had to do with the ammonia production. It's stoichiometric production of ammonia from urea. So you have grams of ammonia you got to get rid of, and that's why you had this massive layer of zirconium phosphate. We get away from all that, and we think that probably about a Coke can size of sorbents plus some charcoal in the circuit will take care of the other toxins and maintain mineral electrolyte balance.
Since we have some Sprint investigators here, can we make some comments about blood pressure control and hemodialysis treated population insights therein, measuring blood pressure and what the target is?
Very interesting question. As you know, we don't measure blood pressure properly in the dialysis unit. And I think that's one of the major factors we have in trying to determine what an appropriate blood pressure target should be. There have been some studies that have looked at what pressure measured during dialysis best approximates blood pressure at home, and it seems to be the post-dialysis blood pressure, but again, we're not measuring this on a very accurate way. I think these new blood pressure monitors that will use technology that is cuffless will give us more accurate blood pressures, and that will allow us to actually perhaps do some clinical trials to figure out where these patients need to be in terms of blood pressure control, because we really don't know. We're just guessing what we need to be. And of course, part of blood pressure control in dialysis is making sure the patients are euvolemic. And that's a whole nother issue in terms of deciding when a patient is euvolemic. And, there are a number of technologies that are being looked at to try and get to that, although I'm not sure any of them are ready for prime time yet.
More questions?
Hi, I'm a dietitian. Working healthcare analysis for years. My question is for the nurse. And so, I know there's nothing that happens in healthcare without the nurse, right? And I recall instances when I was dialysis where we had to cancel the dialysis. So I was just curious, do you know of anything that's being done to incentivize nurses in healthcare to stay in healthcare? Because I know it's a real thing.
My answer would be no. I think that a lot of organizations, including like the American Nephrology Nurses Association, are trying to find different ways to work with universities and such to solve a crisis that's happening right now, especially with nursing, people not going into nephrology, instead assuming more hospital roles and not finding nephrology as sexy as emergency room nursing or things like that. But I think that, at least from where my organization is at, I can speak to where that is, I do not always look for a nurse who has that much experience. It is something within their personality that I seem to be good at connection and networking and finding people to come to my organization or mainly to me. But you have to grow them as a person as well. You have to make them feel like they're contributing to a specialty, like I said, that's of an expert level. I think everyone has been struggling with the nursing crisis even since COVID, that a lot of nurses that I even know left hospital-based nursing, went remote, remote working, obviously pulled away from patient care. So I also don't believe that nurses control everything, because dietitians, nutritionists can definitely have a major impact on patients, especially from the CKD education position, where they need a lot of encouragement regarding food intake, because that can also impact their progression with kidney disease. So I would give you as much credit as a nurse would. But I think that the leaders in nursing right now are really trying to recruit nurses from another level. That's why I think the increase in home dialysis and also in-center self-care will help alleviate some of that burden that we have a challenge over the next 5 years to really work and develop. I think we have a lot of organizations working toward promoting nursing, especially nephrology nursing, as a unique specialty instead of a subspecialty.
One of our former fellows seems to be enthusiastic about bringing the dialysis unit to patients and or hospital. Does anybody have any experience? In other words, you go around with a truck that does dialysis. I go to different people's homes and or nursing facilities where people are not familiar with dialysis, and you, meaning the nephrology group, do the dialysis where they are located.
Yeah.
It sounds good to me.
I would say that there's a collective thought. Actually, we've been trying to look at some underserved areas, and I know that parts in England, UK, I believe, also have a more portable dialysis. It's like a van with a few machines on it, and we were actually discussing this in regard to 2 other patient populations. So I think that it's a thought, but not of a typical reimbursement model. Like if you were driving just a standard vehicle around with the, how far would you be able to go? And having more personalized dialysis experiences. I've also traveled to Australia and New Zealand, where they actually had for self-care homes that were set up for swipe card access, where you could dialyze anytime you wanted to, and all you needed was a swipe badge and just put it through the door. And I was wondering why different communities haven't thought of utilizing those processes along, and we've had conversations with different leaders in different communities to say, would you consider having an alternative in your community, meaning that similar to the van or the truck. I've only used the truck, the 18-wheeler, in disaster situations where I've worked with the National Guard and during Katrina, but it is a portable solution for different areas, especially in underserved neighborhoods, where the density, I think in rural areas, that would be kind of helpful to have it more centralized and away from that. So I don't know if anyone else wants to share, but that's just some of my thoughts.
How could that be different than, having the government or whoever pay for an assistant to do the dialysis at home? I don't get it, except in situations like emergencies, something like that. But in normal situations, there is a truck that stands up in the street. The patient comes from his or her home and dialyzes, and then the truck leaves.
Yeah.
That seems a little bit too much for something where I can simply pay the person who wants to do the dialysis for them, which is a model that exists.
Yeah, so I think you have some inconsistencies between states like Texas and the middle of the country. There's about 12 different states that have very relaxed staff assist rules. And Texas is one of the largest, home staff assist, programs in the entire country. Yet in New York, they won't allow you to do it. They'll allow you to train in the home. Things like we've utilized the CDAP program with Medicaid. I think that's something that people have not tapped into with people who are underinsured, that a family member or someone that they find can be their dialysis partner. That's how in 1981 in the paper, that's specifically what they said. It was, somebody finding a care partner for themselves. It didn't necessarily have to be a family member. And in that model, it was particularly a family member, but there's some benefits with the Medicaid system right now that actually alleviate some of the economic pressures that a family member may have in order to provide the care of a family member at home. And I don't think we utilize that enough. So they may, I've been working with Home Alliance. I'm on 3 different CMS committees. I think that we have proposed this sort of thing, even with the utilization of peritoneal dialysis, that we could have a staff-assisted model to go in, and it would increase the numbers on dialysis. That's why it was interesting that a colleague handed me this paper last week. So I think that as a provision of care model, I think that there is a lot of work in progress right now to look at these different things, and a lot more work to get it to an acceptable way that CMS will accept and allow us to do it.
The University of Utah actually, throughout the years, has done that periodically with higher help. When we are asked by Nevada, surrounding states to do that, we provide paid help to do it. And I know of at least one company now that is more or less advertising that that's what they specialize in, is to provide the paid help to do hemodialysis at home.
What do they do to their home?
Yep.
Not in the truck.
Not in the truck, in the patient's home. They just have a...
Yeah, they'll come out.
Right.
Yeah, that's the point.
Yeah.
Right.
But like I said, the regulations are totally different between 12 states and the other remaining states. So you have to equalize all of those regulations in order to make it more accessible.
More questions? Yes, ma'am.
One of the challenges of providing solo home hemodialysis is the safety, having saved your patients. Can anyone talk about the future?
In terms of traditional nocturnal home hemodialysis, the sorts of things that you have are remote monitoring where you can see the patient alarms. You also have moisture detectors to look to see if the needles are deaccessed. You also have a moisture detector under the machine to see whether or not There is a leak from the machine itself. Clearly, there's a lot more that can be done. As we heard before, there are a lot more sensors that we need to have on our dialysis machines to help in terms of monitoring, adjusting prescriptions based on real-time monitoring. I think in terms of overnight dialysis, that's really going to be the future in terms of integrating the different monitors so that different parameters of the dialysis prescription can be adjusted in real time.
And any changes in the cannulation or like the needles that we, any innovation in that right now to prevent the dislodgement? Just wondering if anybody has any ideas on that.
So from a training perspective, I'm more a tape person. So during dialysis training, I will walk into the room and tell the patient if I can pull this needle out while you're doing your dialysis, you do not have enough tape on your arm. So I use probably 3 or 4 different taping techniques along with Coban and different things so that we have had, I would say in the last 3 years, 2 needle dislodgements that were not during nocturnal treatments, but were during awake treatments, and it was because the patient clearly lacked the taping. So, we also have a lot of, about 25% of our patients who are on catheters, so dislodgement of, that has not occurred. I think it is the training that is most important. And I think that during the training that you have to go through emergency type situations over and over and over again, and even simulate them in the room where you actually make them happen so that you can have a patient who is not anxious and can get through an emergency. In the last 8 years where I am, or longer, I can only account for the time that I've been there, is that we have never had a 911 call during a nocturnal or solo treatment where someone had a disastrous type of event happen on the machine. So I think that's fairly good.
That's good to know. Yes, absolutely. Any other questions? Yes, Dr.
Well, that whole field of sensor technology is moving extraordinarily quickly. And there are already a number of different entities that make multi-parametric sensors that'll measure electrolytes, measure pH, et cetera. None of them have been deployed in this kind of capacity. We just have not done, this is just my view, what we should do in this field to ensure safety. You would also think that I will tell you, Bill Peckham always said whenever he could sort of tell when his chemistries were off by how he felt, and he would give himself an extra treatment at home. But you could do that by sensor. If somebody gets hyperkalemic or something else, significantly acidotic, where a sensor would send a signal to the patient and to the provider if you're at home, to dialyze then. So you would think that we should, if ever there was a patient population where sensing electrolytes is important because they can change dynamically, it's in a kidney failure population. So yeah, now, the glucose thing didn't happen overnight. The very first insulin pump was made in the 1970s and never commercialized at that point in time. It was made by a college dropout at that time, Dean Kamen, who's become a serial inventor, including the Segway. But the NIH funded at the rate of about $100 million a year in the type 1 diabetes program for 2 decades, put a large amount of funding into, in collaboration with the JDRF, Juvenile Diabetes Research Foundation, huge amounts of money into public-private partnerships for companies to develop continuous glucose monitors and insulin pumps and Bluetooth connections between them. And it was iterative over an extended period of time that they improved until now, about a half dozen so-called bionic pancreases are being approved and are going into use. LVAD, same story. The NHLBI funded LVAD research continuously, and they actually learned initially from the NIH dialysis programs, but the NIH dialysis programs, the artificial kidney programs, were stopped in the 1970s, and these other technologies kept on going to where they're now incredibly mature and developed. So we're way behind in the field, and we need public-private, we need basically to coalesce a group of people, and patients are the best advocates for themselves, to say it's not tenable that we're not investing in better technology for kidney failure, just like we have for heart failure or we have for pancreas failure.
Jonathan, I wonder if there's a difference between monitoring glucose versus in dialysis. I worry a little bit about checking it for safety versus checking it as a target of treatment. I worry about the patient saying, hey, my potassium is low enough, I'll stop my phosphate. I think there's a little bit difference there, isn't it, or not?
Well, I think you have to know. You know, it was interesting, the New England Journal, the first paper that I saw of 24 hours of a bionic pancreas, they insisted, the FDA insisted that there was somebody in the room for that 24 hours. If the patient went for a walk, the person went with them. Because, you know, you get too much insulin and you get hypoglycemic and can be lethal. So, you know, anytime you have a solute that you can measure in the blood that is the target of the disease process that can be lethal if it gets too high or too low, you want to know it. You want the patient to know it, and you want the caretakers to know it. So if we can develop the right sensor technologies and the right feedback loops to clinicians and to the patient, remote monitoring why can't we do that?
Well, yeah.
Isn't it better to know than to not know, than once a month to measure labs and have no idea? You know, after the fact, you find out some of your patients came in with a potassium of 3 and some came in with a potassium of 7. It would be much better to know what's going on with the patient.
No, I agree. That's why I think that's doing it for safety. I have less problem. Urea, KTV, we did it in the hemo study too, right? We were talking about what, almost 30 years ago, using online urea sensor. But what I was referring to is using it as a target for treatment. Because if we use, let's say, urea, KT over V is urea is our treatment end time is, then you are back to a Frank gauge KTV of 1.0, right? Instead of time or middle molecule. That's
Totally
what I'm talking
agree.
about. Yeah.
Totally agree.
Great. Thank you so much. If there are no more questions, I'll give it back to Dr. Ibarri.
The time has come, it's 5. I mean, we have had a very interesting day. I really thank very much all the fantastic group of the speaker. I have learned a lot, and many people, I think, have learned a lot. This has been a very view into the past. I mean, how things happen and how things have been happening and how possible things will go in the future. So thank you very much again, and we close the symposium.